So clinical judgment is an essential skill that involves the interpretation of patients' needs, their concerns or health problems, and the decision to take action or not to use or modify standard approaches to something, or to improvise new approaches on the basis of a patient's response. So, for example, patient is a diabetic. We give them insulin for their diabetes, but maybe they are on what we call a sliding scale. So that scale tells us how many units of insulin that they get. Well, the clinical decision comes in when we have to decide. We take their blood glucose, maybe their blood glucose, why is the marker in here always missing? Maybe their blood glucose is 150. Well, based on that sliding scale, I'm going to give how many ever units are on there. Maybe their blood glucose, when I take their blood glucose, is 112. Or I'll give you even better. Maybe it's 100. But maybe on top of that sliding scale, they also get a scheduled dose of insulin, 5 units, regularly. If my patient has a blood sugar of 100 and they have 5 units of scheduled insulin, I may make the clinical decision, hopefully yes, to hold that and call the doctor before giving it, okay? To make sure that the doctor still wants us to give it, because that could, what we call, bottom out or decrease my patient's blood sugar. That is a clinical decision. That's what makes us as nurses different than a tech or an LVN. We have clinical decision making that we do, okay? Nursing, we apply knowledge. So in the next 2 years, you're gonna have all kinds of knowledge that you acquire. What is diabetes? Why do we give insulin? What does it do? Okay? That's knowledge that you acquire. All of you should have learned this week how to take vital signs. And hopefully you read the book and you know why we take vital signs. What do they mean? What do they tell me about my patient? They're one of the first signs that tells us and indicates that there could be a decrease in our patient's condition. Right? That's knowledge that we bring to the table. Clinical experiences. At some point as you move forward, and this is my class where all my JPS people are, right? So some of them, or those of you who already have a job, you already have some clinical experience. You've seen where a patient's blood pressure was too low or too high and you needed to go and inform the nurse. Well, now you're the nurse and you want someone to come inform you. So you have to teach your techs or your aides to do that. Please come tell me if my patient's blood sugar is low or too high. And as you build on those experiences, then we know we get better at dealing with the next one, at seeing what things we need to pull out, what cues is what we call them. Assessments that tell us something is going on with our patient. One of the easiest ones and the first ones that you're gonna learn is patient falls. So what tells me my patient is at risk for falls? Any guesses, thoughts?
Age.
So age could be an indicator.
Previous fall history.
So when you say age, which way are you talking?
65 or older.
And young.
Okay, so elderly
Younger.
and younger. Kids are clumsy. True story. So my elderly and my very young patients would be at risk for falls. Now, here's some clinical decision making for you. Would I put a yellow armband on a kid?
No.
But, so the answer was no. But do I need to think about the fact that their sense of themselves and their body is not the same as an adult and they're at risk for falls or hurting themselves or injuring themselves because they don't have that body control yet? Yes. Babies fall into buckets because their heads are heavier than the rest of their body. So that's a safety concern with a kid. Okay? As they get older, that changes. When they get old, we gonna put an armband on them because they can fall, right? What are some other things that might tell me my patient's at risk for fall?
Previous falls.
Maybe they've fallen before. That would be a reason to think that they're at risk for falls.
Muscle relaxer or something like that.
Maybe they're on a medication that puts them at risk for falls that I need to be aware of. Something that is gonna give a sedative effect, such as a pain medication, or maybe a psychotic or mental health medication.
Disease conditions such as osteoporosis, confused patient.
Yeah, so maybe I have a patient that has an illness or a disease that right now puts them at risk for fall. For example, she said confusion. If I'm confused, am I aware of these cords that even though I'm not confused and not elderly, I'm apt to fall over because I'm clumsy? Even though I'm a really functioning adult, I'm just clumsy. So I have fallen in this class, no, well not fallen, I've tripped in this classroom over cords up here. But confusion, am I aware of those things if I'm confused?
No.
No. What if I have osteoporosis, have some type of mobility, or osteoporosis affects our bones, the frailty of our bones, or maybe I have just regular arthritis that affects my joints. Might that put me at risk of falls?
Yes.
Yes. Okay. So those are all assessments or knowledge that we have as nurses that makes us think. What do I need to look for? What do I need to be aware of with this patient? I'm looking as I see my patient. What's their gait like? Which means how are they walking? Okay? Are they on that medication that might make them that way? Have they fallen before? That's all assessment data or cues that we want to know. We're coming there. Their environment. Okay, so I talked about these cords up here. That's an environmental hazard that could make our patients at risk for falls. When we go into their homes, maybe they have a rug that is lifted up, or maybe they are a pack rat. Maybe they're that hoarder, and they've got stuff everywhere that puts them at risk for falls. Okay? Or they have stairs that put them at risk for falls. Okay? There are going to be things in the hospital that are going to put our patients at risk for fall. Okay? If I'm attached to an IV and oxygen and yeah, STDs, I got a drain hanging off. All those things are going to put our patient at risk for falls. Okay? Would you say, Modesta?
No, I said maybe a Foley catheter.
Yep, they have a Foley. That's going to put them at risk for falls. If they wear glasses, maybe I'm blind and I don't bring my glasses, I'm going to be at risk for falls. Okay? So very good, guys. So then next would be professional standards. Remember we talked about some of those last week? What were some professional standards that we talked about last week?
Introducing yourself when you walk into a patient.
I cannot hear nothing you just said.
Introducing yourself when you walk into a patient's room.
Okay, so that's practice that we do. So,
Kind of like the code of ethics.
so our code of ethics is gonna fall in there. Agency policies are gonna fall in there. Do you guys remember me talking about our patient safety goals or QSIN standards? Those safety standards or those standards of care that are expected. So when I walk in the room, it's expected that I introduce myself and I check my patient's ID band. That's a standard that all nurses should be doing. When we pass meds, we have our 6 rights of administration. That is a standard. So when we're making these clinical decisions, we also have to consider the standard of practice. What is the standard that all nurses should be doing? Okay. So, as you can see, it's important for nurses to work on their critical thinking. As we develop professionally, we acquire better critical thinking skills, and they allow us to face each new patient, care experience, or problem with open-mindedness, because some things that we didn't consider that also go into this are cultural considerations, age considerations, and we'll talk about some of that a little bit more later. We're able to be a little bit more creative in how we deal with situation and problem solve. We have more confidence. And then our skill to inquire, which is our asking questions, gets better. So right now, maybe you ask 2 or 3 questions that come to your mind. As you become a nurse and acquire more knowledge, those questions are going to become more. You're going to ask more questions, and you're going to get better at asking questions, and your questions are going to get more specific to what's going on. Okay? And so we call that continual inquiry. Okay? So critical thinking, it's acquired through experience, commitment, and active curiosity. So curiosity doesn't kill the cat in nursing. Curiosity makes you a better nurse. But it's not a simple step-by-step thing. It becomes circular. The pieces, even though they go step-by-step, they're often intermingled. Okay? So, I already told you registered nurses are responsible for making accurate and appropriate clinical decisions or judgments. So we have to learn to question, wonder, and explore different perspectives and interpretations to find a solution that benefits the patient. We have to learn how to recognize that there's an issue, interpret what's going on. So if my patient has shortness of breath and their statting, their O2 saturation, oxygenation is 89, I have to learn to recognize that that means something is going on with my patient's oxygenation. That probably in most cases they're going to need some oxygen. And then I need to further look into this problem, calling the doctor, or figuring out why they're having that issue. And then responding properly, which is, giving them oxygen, or maybe my patient, I'll say my patient was asthmatic, so maybe they now need respiratory to come up and to give them an additional treatment to assist in their breathing. Does that make sense? Okay. Each patient's problems are unique. There are a product of that patient's physical health, their lifestyle, their culture, their relationship with their family and friends, their living environment, and their experiences. That's a lot, isn't it? And maybe we don't think about that before now with someone's health. We think, oh, they have asthma and that's it. But what if I come from a family who doesn't believe in medication? Or the parents don't understand the importance of giving the medication on a regular basis. Maybe I'm a severe asthmatic, but I like to run, and I say, I don't care if you're telling me I have asthma, I'm going to participate in these sports, and it's causing me further issues. So that patient would need patient teaching. Okay? Because sometimes, unfortunately, no matter how much we want to do something, our health will not allow us to. Okay? Maybe with our mental health patients, they've been diagnosed with a mental health issue, but they're afraid that their family is going to look at them badly. Or maybe their family has already told them, oh, you don't have that. They're just, it's all in your head. There's no such thing as depression. It happens. Families say that. So then how is that going to make that patient feel? Maybe they decide not to take the medication. Okay. So friends and family can affect the decision making and how we care for our patients. Okay. Their experiences. Maybe they took a medication before and they had a bad reaction to it, or maybe they saw a friend have a bad reaction to it. Can that affect their decision to take it? I don't know if it was this class, but I had a patient last semester who we took care of, me and a student who was having a bleeding issue. The doctor came in and told her, I'm going to put you on this medication. It has not been proven yet to work in patients who are your size, but I think we should put you on it. Okay. That patient's not a nurse, right? They don't have a medical background. They don't know like we do, or like you will do, to ask more questions. So the patient's like, okay, my mom was on that medication. She didn't have any issues. I'm going to take it. Her experience with that medication, knowing her mom had taken it, in her head, oh, it's okay. But does that mean she's going to have the same results? No. Does that mean that she should not inquire further because her size, her condition may not be the same as her mom's? But patients make decisions like that, and it's our job to educate and to advocate for our patients. And that all becomes part of our clinical judgment and our critical thinking. Okay.
Can I close the door?
Oh, yeah. Alright. So, as a critical thinker, we consider what is important in each clinical situation. And then we think about what are the alternatives, what are the ethical principles involved, and then we make an informed decision about the care of our patient. This is when we ask why, what am I missing, what do I really know about the patient's situation, what are my options. We use evidence-based knowledge or research and our clinical expertise to inform our critical thinking. It requires a habit of asking questions. Okay? We have to stay informed about medical, what's going on in the medical field with different conditions, different treatments, and such. Okay? We have to be honest about our personal biases. Okay? If I don't agree with, maybe we have a mom who is a mental health patient who decides not to take her medication while she's pregnant. Okay? And there's good and bad on both sides. But if we feel a certain way, are we trying to push our opinion on our patient? Or are we being objective and truly telling them both sides of it? And that comes along with different things, guys. These are just examples that I'm giving you now, okay? But it's gonna come up in other situations. Maybe we have a patient who has a specific religious belief and they have a holiday or a special,
Clinical
okay, thanks. A special celebration that's going on. So that causes them to so I had a patient before where their religious beliefs, they couldn't have any electricity going on in the room after sundown. I forget the name of the holiday, don't worry. But that meant if we as the hospital, the staff caring for them, whether it was nursing or the doctors or whoever, we had to give all cares before that time. That included pharmacy, because all medication had to be passed. Any antibiotics had to be passed. And one thing that you'll notice is that all hospitals, so that we don't have things getting all crazy, when you come in, medications are timed pretty much the same, okay? So all your morning meds are given at 8 or 8:30, whatever that hospital decides. Then the next medication may be given at noon, 5, whatever, so on and so forth. Whatever the schedule is for that hospital. Daily meds are given at a specific time. Meds that are given twice a day are given at specific times. But when you have a patient like that, those times have to be adjusted. If I don't believe the way that that person believes, am I still willing to make those adjustments? Or how willing? Or how kind am I in making those adjustments? Do we offer those adjustments? Okay? Because that patient may be the patient that says, and she did, well, if I have to get it after 5, then I'm not going to take it. I don't want those meds. So do we say, okay, that's fine, you're just not going to take it, you're not going to be treated? Or do we find a different solution? Okay. So, it takes work and focus on options to solve those problems and have a continuous attempt at this. Okay. So ultimately, critical thinking also involves reflection. We have to have the ability to think about our experiences and how they affected a situation. How can I change the outcome in the future? So maybe this time I didn't know that if I gave my patient that scheduled 5 units with a blood sugar of 100, that it was gonna bottom them out. You're gonna learn real quick that it bottomed it out, that it bottomed out, and that you should contact the doctor before giving it, even though it was scheduled. Okay. I had to use that critical thinking. Okay. And then thinking about in a situation, if I had have taken those vital signs more often, if I had gone in and done an extra assessment, all those things become a reflection on our experience that then inform our critical thinking in the future. So it's not intuitive always. Everybody doesn't always think about their past to inform their future decisions, but we should. So it's really bothering me that I do not have my marker in here. So I'm gonna have to go get one. We're gonna take a real life example. How many people have ever run out of gas? Okay. So when you got up in the morning, huh?
All the time.
All the time. Oh, wow. When I was younger, I did more often. But as an adult, not so much. But you get up in the morning and you look at the gas tank and the light is on. We now have a decision to make, right? Am I going to the gas station or am I going to where I needed to go? Okay, we got some thinking.
20 miles.
She said it depends on when the light comes on.
I know my car.
I don't know. I know my car.
I know my car. So different cars, it makes a difference how many miles you got when that light come out. Huh?
If the light just came on, I can still get to work.
You just can't get back home.
You see right next to JPS is all I'm saying.
Okay, so no, all of these things is what I'm talking about. All of these things are gonna inform your decision, right? So she says, you said I know my car. You said 20 miles. Some people might have 10, some people may have 40. It just depends on the vehicle. excuse me, because all vehicles, especially your newer vehicles, have what they call a reserve tank. And that's when your light goes on, is when the reserve tank is beginning to be used. Okay, so she decided she was going to work because she said she can get some gas at work. Okay, what's your name? Rachel? Okay, so Rachel said you got what kind of leeway?
Like, if you're 1 minute past 5 minutes, you might as well go to Starbucks and hang out for an hour because you're late away.
What are you talking
About time, so I gotta get to work.
Okay, so you can't be late for work. That's what she's looking at. I can't be late for work. So I don't got time to stop for gas. Because if I'm going to be late, then I might as well just be late. Okay, what's your name?
Jordan.
Jordan decided she can go to work. She can go home. And she might even try to work tomorrow on that light. Okay. Jordan gonna run out of gas. Okay. So, if we're using our critical thinking, what are some things that could have alleviated this situation?
Going to get gas. You get gas before.
We didn't have time to go get gas. We had to get to work.
You have to check in the
You
morning
wake up
before you
earlier
leave
and
how much
get
gas
some
do you have in your car.
We already did that. We established that we got up and we got in the car and the light was on.
So you don't get the gas before you.
We don't have time. We have to go to work.
You knew the night before.
Okay. Here we go. That's what I'm looking for.
The
So,
night before.
could I have gone and gotten gas the night before?
We was tired.
I might have been tired, but that would have kept me from being late in the morning.
It's raining.
Okay, so I could have got it the night before. I also heard someone else give me another suggestion. I could have got up earlier. Ooh,
Oh, fill up your tank.
I'm really not feeling that one. But I could get up earlier and go to the gas station. Because if I left 10 minutes earlier, that would give me enough time to go get some gas. Okay? What were you?
Maybe fill up your tank every week. Just on this particular day, just fill it up.
Okay, Modesta says have a set day every week I'm gonna fill up my tank. Okay? My mom has a set fuel line. Her tank is never below a half a tank of gas.
Me too. I don't go.
So she don't ever run out of gas. Huh?
Mine's a quarter. I don't go below a quarter.
So she says a quarter of a tank. That's about my fuel line thing now. I will tell you the day I stopped doing that. So I used to live in Illinois, and this is just a quick story. I used to live in Illinois. It snows. My mother does not believe in running out of gas. If you run out of gas, it was your fault. And she had gotten to the point where, like, I'm not dealing with you no more. Well, my dad was at work, and I ran out of gas maybe like a mile, a little bit more than a mile, maybe like 10 miles from our house. It was cold and it was wet. It was snowing. And my mom, I wasn't calling her. There was no way in the world. And I literally was across the street from a gas station, but I did not have cash to get gas. So my dad sent one of his coworkers to come and give me gas money. But I swear I would never ever run out of gas again. On top of the fact I have a kid and I'm not walking with the kid to get gas now. But that takes critical thinking. It takes planning ahead. It takes reflection on previous experience. Okay? Let's talk about another situation. And I'm talking about this because, guys, you already do it every day. We're just going to apply it to nursing. Okay? You got to ask yourself more questions. Let's talk about a flat tire. Okay? I know that today I have class. I have to be at class at 8 o'clock. So I leave the house and I get 10 minutes out of the house and I get a flat tire. But I gotta be to class. What are some things that are gonna go through my head? What can I do? Martin.
You try to check if you have a spare tire at the
Martin says we're gonna check for a spare tire.
First thing I'm
Tiffany,
doing is contacting you.
call me.
Yeah, well, no. Contact your professor.
Oh, okay. That's sweet.
No, I'm just gonna tell you. I have a flat tire. I might be late.
Oh no, I appreciate it. So I'm gonna contact the instructor. I'm gonna contact my boss and say, hey, I'm gonna be late. Okay? Might not be the first thing I do because I'm probably first gonna freak out about the flat tire. But yes, it's gonna come in that list of things I'm gonna do.
Then I call AAA.
So she's gonna call AAA. Any other thoughts?
I'll call my husband.
Modesta's gonna call her husband.
See, my husband would say, I'm gonna call AAA. That's what we have it for.
I will call a AAA. Melinda,
If my car gets towed, I'm calling for Lyft or somebody to get me to class.
you said if it gets towed.
Like, if she called AAA, like, let's say you didn't have the
Oh.
like it had to go.
Okay, I'm like, wait, how did we get to towing? Okay, so her tire can't be fixed. It's got to be towed. So we're gonna get a Lyft or a Uber. Okay.
I'm just gonna change my tire.
Rachel's gonna change her tire. So her and Martin, they gonna check for the tire and they gonna change the tire. I have learned how to change a tire, but I'm past that point in my life where I'm gonna change a tire. I know it sounds really girly now, and I don't even mean it because I do know how to do it. I'll be like, oh, I'm gonna break it down. I'm gonna just call AAA people. What's your name? Sarah. Oh, I should never forget yours. I call that name a million times a day. Okay, Sarah.
I would call my dad.
I'm with you. If I'm close to home, I'm gonna call my dad. Okay, so we have all these different options, right, that we have to think about. Do I have money to call an Uber? Do I have AAA? Is my dad close enough to fix it? Is my husband at work? Can he get to me? Does he have the kids? What is it gonna require? So we have to think about all these different options, okay? Can I drive on the tire? You know, is it fixable? Because sometimes it's not fixable. Did I have a spare tire? Those are all questions that we're asking, all options that we're gonna consider, okay? So now we go back to our patient. We're gonna apply it to our patient. With the falls, which you guys did a really good job, so it's gonna be a really good example because you already know all the answers, okay? My 65-year-old elderly patient comes in. What questions am I gonna ask him? You already told me the information that makes him at risk, so what questions am I gonna ask so that I know? Have you fallen before? Do you wear glasses? What medications are you on? Not are you on this medication, because a lot of times our patients aren't gonna know those kind of facts, or not all of our patients are gonna ask that, but we are gonna have that knowledge, right? Or we can look it up. So our question is going to be, what medications are you on? Or are you on any medication?
Are you
Can you guys raise your hands just so we're not talking over each other and you can all hear? And-
incontinent of urine?
Okay, can you hold your urine? Okay? I'm not gonna ask it like that, but we do wanna know if they're continent or not. Okay, Tiffany.
Do you use mobility aids?
Do you have an assistive device? Do you use a cane? Do you use a walker? Hopefully not a wheelchair, because if you're walking, that's scary. But do you use some type of assistive device? And I'm contemplating whether I'm calling on you because you're LVN, so you should know a lot of these questions.
Okay, so are you on diuretic?
Okay, so she's being more specific. So Martin said, what medications are you on? She's telling you a specific med that you're going to be concerned about, and that's a diuretic. Okay? Melinda.
How's your balance?
Am I going to ask that?
You can assess that.
I'm going to observe that. I want my patient to walk. Okay? But we do want to know that information. Very good. Rachel.
Ask if they have like a history of drinking or any.
Okay. Why do I want to know if they're drinking?
Well, sometimes our patients can come in and they have a history of drinking,
And I'm sure not everybody can hear you.
sometimes some of our patients, like in behavioral health, will come in and they have a history of drinking, and they like it may send them in like if we all of a sudden stop their drinking, and now they start having withdrawals, they might become confused or agitated.
Okay, I like it. So, do you have a substance abuse problem? We usually ask them, do you take any, are you using any recreational drugs? Do you drink more than, well, there's numbers, so like 2 to 4 a day, 5 to 7 a day, whatever. And that would tell us that our patient could possibly be at risk for falls, because if they're drinking every day and they're relying upon that, they could start going through withdrawals, and that would put them at risk. Ooh, we have a nurse in the back. Are y'all ready for a call a nurse? Y'all need a lifeline yet? Or y'all got some more for me? Don't rely on the lifeline if you don't get it. All right, what's your name?
Amina,
Amina. Okay.
would you ask them, do you know what day it is, just to like gauge their mental?
Okay, so we always ask orientation and level, like the questions to tell us if our patient has a level of consciousness. Yes, alert and oriented. I like it. Okay, that's good. Oso.
Oh, sure. Yeah, you want to ask if they live by themselves or they live with a family.
Is that going to put me at risk for falls, though?
Just trying to look to see how they have help at home. They want to walk around in the house. They have someone around to help them.
Okay, so I like your question, but not yet. That's going to be more applicable when my patient is going home. It's not going to tell me right now specifically what's going on with my patient. We do want to know that information though, but not yet. Okay, I saw, what's your name? Natalia. Are you in this class? I'm in Monday's class. Okay, I was like, I didn't call your name this morning. All right, Natalia.
Past medical diagnosis.
Okay, I want to know your past medical history. Why? Do you know why?
So that you know if like they have osteoporosis.
Okay, do they have some kind of medical condition that puts them at risk for falls? You're not Steven, you're Steven.
That's what
You are
Andrew.
Andrew. Are you in this class? Okay. Today, so guys, normally, obviously you'll be in your day's class, but when we have holidays and stuff, and we're not supposed to, so we keep it kind of, because you're really not supposed to do that, but I do give people the option to come to my class, because some people it's better to hear lecture than it is to hear a recording or see notes. So that's why some of Monday's class is here. Okay, Tiffany.
Any past injuries?
Any past injuries? Yes. Okay, that could put them at risk for falls. Modesta.
Can you offer to take them to the bathroom?
Why am I going to offer to take them to the bathroom?
It helps prevent falls.
Okay, so is that assessment data? Right now we're looking for assessment data. No, it's a question. We're learning, guys. This is where you learn. This is where we make mistakes. This is where we talk about it. This is how you figure it out. You didn't know that before today. Did you even know what the nursing process was before this week? Okay, so it's okay. But I'm going to ask you questions because I want you to think. Because those are going to be the type of questions that you get on your exam, that you get on NCLEX, is making those differences. I need to know what is an intervention versus what is assessment data versus what is evaluation. I need to know what those different pieces are. So what you told us is actually an intervention. Okay? And right now we're talking about assessments. Steven.
Yes, if their vital signs are too low.
I want to know their vital signs.
Yeah.
Why? Do you know?
If their pressure is too low or too high, if they stand up, they could pass out.
I don't know about too high, but definitely too low. So if it's too low, they could be dizzy. And that could be a reason that they could fall. Oh, you guys are good. I can just sit down and not do my job. I think y'all know everything all right. Martin.
I want to ask a question. What about when a person is die or the person not ate before, I don't, if I'm getting me.
I didn't hear you.
If you're not able to, you don't eat and you feel dizzy, maybe because you want to lose weight.
Oh, have you eaten today?
No, actually, yeah. Like a question like that.
Sometimes people come in say they're like on the keto or like restrictive diet, and then if you ask them that, because like if the cafeteria food isn't something that they eat, and then they might be refusing certain stuff. We've had a lady fall because she was carb counting and refused to eat cafeteria food.
Okay. So I like the way that your thinking is going, but it wouldn't necessarily be a question that I would ask like about right now for falls. If I had a patient that came in and ended up with a diagnosis of dehydration or something like that, or their symptoms was looking like that, further down the line we may ask that, but right now we're just talking about initial assessment, and there's nothing in my initial assessment that would lead me to ask that. Okay? But your line of thinking is not bad. Someone who was carb counting or not eating could end up being a fall risk. But when we initially see a patient, that's not usually a question that's going to come up immediately. Later on, it might be a follow-up question.
On that, we would ask about basic diet, right? And then if they said, oh, I'm on the keto diet, then we would probe deeper at that point.
Okay, so don't confuse admission data.
Right.
And right now we're specifically asking about falls. Okay, so on admission, we ask a lot of questions and it would include diet, and we may probe a little bit more. But right now, we're asking about falls. What would we ask if we thought to determine if our patient was at risk for falls? You are Elizabeth.
Do we have their medical history at this point in some instances and not in others? Or?
Well, we said we were going to ask. Natalia said we were going to ask. And it depends on if they've been seen at the hospital. You may see a little bit of it. It may be accurate. It may not be accurate. We always ask either way. But yes, we want to know their medical history.
Yes. So, kind of like
Janet or Janice?
Jeanette.
Okay.
What Rachel was saying about like diet. Like sometimes if they're diabetic, I know at assessment, even though it has nothing to do with like, you know, what they ate, but if they're diabetic, sometimes if they come in the morning and they haven't eaten or haven't had their insulin and their blood sugar is low, we just don't want them to bottom out. I can kind of see where
Okay, so would my question be about diet then?
No, that's under medical diagnosis, right?
What would my question have been? It wouldn't have been about their diet.
It would have been.
It might have come to that. Remember I said that might be a follow-up question.
So when you're asking in assessments, like we are asking, questions about them, we could ask, do you have a medical condition that can
Okay,
prevent
so
us?
that's where your question is going to come from, is their medical history. Once I find out my patient is a diabetic, then that might lead me to ask, are you taking insulin? Because we want to know what medications they're on. So those questions about diet are going to be follow-up questions. It's not going to be a question that initially would lead me to think that my patient has a fall risk. Okay? All right, y'all ready for your lifeline? Oh, not yet. I got more questions. Leslie, they ain't trying to use you. They got this. Okay, Natalia.
Could you, if they have a family member or significant other with them, ask if there's anything maybe they've left out, like if they're eligible?
You totally just disrespected me. So, if our patient is alert and oriented, no, we're not going to ask nobody else about them because that would be, we always want to maintain our patient's dignity and respect them. So we're going to take, unless for some reason we have a reason to question their ability to tell us an accurate history, we're going to take their history for what they tell us it is. Okay? But good idea if we have a patient that's not alert and oriented. Osho.
I would ask questions about their family background, probably to know their emotional status, or if they are in a state of confusion, going through something.
Okay, you guys are getting into admission questions. We're focusing on falls right now. So his was, do we ask about family history? That is not going to tell me about falls right now. Tiffany.
Are we going to ask anything about their emotional state?
Is that going to make me fall?
If you're a nervous type, anxious type person,
That's going to make me fall?
if you're scared, if you don't have
Not usually.
nervous blocking, you don't have.
Not usually.
Little ladies can make it to the wall or sit down.
Well, that would be age.
That would be age.
Like a lack of
But just in general, having an emotional issue, having a mental health disorder is not going to make me at risk for fall.
confusion would, right?
Confusion would, and we got that one on our list. Confusion would.
But we're talking about
No, we said confusion though. Confusion would put me at risk. So, but we checked already to see if they were alert and oriented and what their level of consciousness was. You got a comment for me? All right, you guys did really good. Really, really good. You like it?
I like it, but the left one out.
All right. Oh, I'm sorry, you got your hand up? Oh, crud. Jordan.
When the last time they've fallen?
All right, so we want to know if they've fallen before.
What made them fall? Like if they were dizzy.
Okay, yes. If they've fallen before and why. I like it. So we did say falls before, we did not say why they've fallen or how they've fallen. Okay, Leslie has one that we missed. What?
Weight-bearing restriction.
Oh, okay. So if they were a surgical patient, do they have weight-bearing restrictions? So sometimes when we have a patient that had usually hips, sometimes knees, right?
Hips, knees, ankles.
The doctor will say you can go home, but maybe only put half the weight on that, or don't put any weight on that.
Some are non-weight-bearing.
On that leg that you had the surgery on. Okay? So are there weight-bearing restrictions? So there's a lot of thought that goes into assessing our patients. And then what are we gonna do? So we got the assessment portion. So I'm gonna flick through forward in some slides, guys, because we got a little bit ahead. So there are different levels of critical thinking. On the first level is where you are. You're at the basic level. You know a little bit more than you think you do, but you're still at the basic level. So basic level, that learn and trust the experts have the right answers for every problem. Thinking is very concrete, and it's based on a set of rules or principles. So my patient has a previous fall, I'm gonna put a fall band on them. That's very concrete. Okay, A plus B equals C. Okay, one that may not be so obvious is the one that you're Rachel, right? That Rachel said about our patients who come in and maybe they have previously they're alcoholic and they're going through withdrawals. That one might not be as obvious to put a fall band on. Okay, so that's not as concrete. All right, a basic critical thinker learns to accept diverse opinions and values of experts, whether it's instructors or staff nurse preceptors, and then you figure out, ooh, not all of them tell me the right thing. Or maybe that's not the practice I want to follow. Now, mostly you're going to get the same answers, but some people's clinical judgment sometimes is a little different. Okay, and so in experience, you have weak competencies, and inflexible attitudes can restrict a person's ability to move to the next level of critical thinking. So you have to move past that concrete where it's always A plus B equals C. You have to ask more questions and be creative, and think about, okay, how far can I go outside of the realm? So if all of you are learning what vital sign ranges should be, so what's a normal heart rate?
60 to 100.
60 to 100 is the range. Now, there are occasions where you're gonna have that little old man or that little old lady who sits at 55, okay? And nobody's gonna care. Not literally, but it's not a priority because they sit at 55 and it's okay. All right? On occasion, you're gonna have someone whose heart rate as an adult sits at 110, and it's gonna be okay. You're gonna have to realize and you're gonna learn when it's okay to have what we call ambiguity. What is the proper amount of ambiguity? How far and when is it appropriate for something to be out of that range? Okay? Yes.
So when you don't know that person, would you just often ask questions, like as a tech, if their heart rate is incredibly low, I might ask them if they're athletic or things like that.
Well, as a tech, you can't make them kind of decisions.
no, but I would
But
ask
as
that.
a
I would
nurse,
ask
would
the
I
nurse
expect
to
you
be
to
like,
ask some of those questions? Yeah.
No, but is it?
As a tech, if you're asking, that makes you, I mean, a pretty good tech, but I mean, you can't really do anything
No, I
with
can't
the
do anything about
information
it, but I might
outside
need
of
to
go
know
give
that.
it to the nurse.
But if you're a good tech,
And
you
I'm
ask those questions.
speaking to that because you have to understand what's appropriate in your role and what's appropriate in the roles that we delegate to. Okay? So it's not wrong for you to be thinking about those questions as a tech right now. But as you move into the role of a nurse, it is very important for you to understand, what is my role? What is my scope of practice versus what is the scope of practice of a tech? And that is not within the scope of practice of a tech. They don't ask assessment questions. Okay? Huh?
I asked a lot of questions as a tech. Similar to.
I'm not saying that it's bad. I'm just saying that normally that is not within your scope. There are techs who know additional questions to ask because maybe they have friends who are nurses or they've been doing it so long, they know what information to collect to go tell their nurse.
Right, but it's still the job of the nurse.
But
to
in
verify.
general,
Yeah.
most techs aren't going to be doing that. Okay? And they can't do anything with the information besides go tell
Right.
the nurse. Did you have a question?
No.
Okay. All right. So, the next level of critical thinking is that of a complex critical thinker. You begin to separate yourselves from the expert and analyze critical situations and examine choices more independently. Each solution has benefits and risks that you weigh before making a final decision. We talked about, do I get my tire changed? Do I call an Uber? That's when you become more complex, okay? Thinking about the options and what they mean, okay? Lastly is the commitment level, and this is where you anticipate things happening before they happen, okay? Without the assistance of others, and accept accountability for your decisions. As a nurse, you do more than just consider complex alternatives that a problem poses. We choose an action or belief that is based on available alternatives and have support for that. Because we take accountability for the decision, we have to consider the results of the decision and determine whether it was appropriate. All right, are you guys ready for a break? All right, we'll take a break here. This is a good place to take a break. So, why all this talk about critical thinking? Critical thinking and the nursing process go hand in hand in making quality decisions about patient care. It is the reasoning process by which we reflect on and analyze our thoughts, action, and knowledge. As a beginning nurse, it's important to learn the steps of the nursing process and incorporate the elements of critical thinking within that. Okay? I like mnemonics. You'll see me incorporate them throughout a lot of my lectures. It's a good way to remember things. So we already talked about add pie. Now you see the pie, and it's an apple pie. So you'll see on NCLEX they'll refer to diagnoses sometimes as analyze. Okay. All right. So you all were required to read Caputi. I need you to write this down. Okay. And if you have your book, I think I asked you guys to bring your book with you today. I want you to write it in your book because it's important for you to understand how this relates because you're doing this in clinical, okay? And I need you to understand how it relates back and how it's helping you to understand this process, okay? So, if you go to pages 28 and 29 in your book, I want you to copy this down. Okay. Your noticing step in Caputi is assessment. This is nothing different from the nursing process. It's to help you understand how to think through the process. And she just gave it a different name. Okay? Interpreting is your analysis or your diagnosis step. Okay? It's what is the problem. Interpreting is analysis. Remember how I said that in the nursing process, sometimes the diagnoses is the same as now? Just put diagnoses so it doesn't confuse you, because we will use diagnoses, we won't use analysis. I just need you to know that at times that is sometimes referred to as that. But analysis and interpreting is the same thing. Okay, that diagnoses, okay? Planning is the responding. Planning and implementation, which is our interventions, all of that is what is my goals, what outcomes do I hope to achieve from those goals, and what interventions am I going to implement to achieve those goals. Okay? All of that is part of responding. And then the last part is evaluation or reflection. Okay? So every step of this corresponds to our nursing process. You were supposed to read chapters 2 and chapter 4. If you didn't, there are 2 pages that I want you to pay attention to. Page 17. I want you to walk yourself through that case study with the different steps and put the steps in there so you understand. Assessment, diagnosis and planning, implementation, and evaluation. Okay? And then pages 28 and 29. The rest of chapter 4 is going to give you more in depth on each one of those steps. If you don't read nothing else for the semester in regards to nurse prep, read that, because it's really going to help you through how you think. Okay? So, purpose of the nursing process is to diagnose and treat human responses to actual or potential health problems. Use of this process enables nurses to help patients meet agreed upon outcomes for better health. So when we come up with goals for our patient, we come up with them with our patients. In addition, our diagnoses, these are nursing diagnoses, not medical diagnoses. These are problems. When we talk about the difference between nursing diagnoses and medical diagnoses, nursing diagnoses are problems that nurses can do something about. Okay? So, effective care planning results from the nursing process. That's why we go through this, is so that we can have the most effective care possible. It's the structure or foundation of our care plan for our patient. Okay, even though in the healthcare setting you don't have a formal care plan like what you are going to write in clinical right now so that you learn the process, there is care planning within the chart. There are all of these pieces are within the patient's chart. There are goals for the patient somewhere in the chart. There are interventions that we do. Our assessment is what we chart. Okay? So it allows us to apply our knowledge and skills in an organized and a goal-oriented way. Helps us to think critically, solve problems, and make care decisions. It's holistic. We talked about all those pieces that we have to consider. Culture, previous experiences, all of that. And it's humanistic. We want to take into consideration our person as a human being. Okay? Give them dignity, be compassionate. And it addresses human responses to medical conditions. It's patient-centered, which means they have input. It's not just our opinion. We come up with goals with our patients, and we want them to participate. If I want you to, as a patient, you're having We talked about the surgical patient. Well, that patient who's non-weight bearing, one of their goals has to be for them to walk, right? If we want them to get up and walk and we say, the goal for today is for you to walk to the nurse's station, and they like, I am not feeling that. Is that goal going to be achieved if they're not participating and they're not a part of it? No. Okay, so we have to, okay, here's what I need you to do. Because we want to encourage our patient to do that. Like, okay, you have to get up and walk. And you have to get up and walk because this is what's going to help you to heal. This is what's going to help you to keep your mobility and your ability to walk. So, what sounds like a reasonable goal? You think you can get up and walk to the door today? Or maybe you can get up and walk to the door this morning, and this afternoon we can get up and walk to the nurse's station because I need you to get up, okay? So we may have to make smaller goals to reach those bigger goals, but ultimately, hey, I need you to be able to get up and walk around this unit before you leave. What's a reasonable way for us to get there, okay? So we're gonna have those conversations with our patient, okay? It has to be individualized. Leslie, she's a surgical nurse. She knows she got to get up. So she had surgery, and she already know, okay, I feel I'm going to get up and walk to the nurse's station. That's fine. Now, I might have to slow Leslie down because she is a surgical nurse, and she's going to be trying to do more than she's supposed to be doing. So I might have to slow her. Hey, maybe we just want to walk to the nurse's station, not around the whole unit this morning. You only post-op day 1, okay? Versus my patient who doesn't have that knowledge, who maybe they're still emotionally dealing with the fact that I had to have hip surgery and I'm 50 years old. They're maybe depressed about the situation, and we can have temporary depression, acute depression over a situation. Maybe they're like, I don't want to get up, I'm in pain, They may not want to get up and walk to the bathroom. And we may have to start with them there. I need you to get up and walk to the bathroom. Okay? So it's individual. It promotes accountability for nursing actions. So every time we write a care plan, there's a part that says the patient will do this, and there's a part that says the nurse will do this. And we're accountable for that part of the nursing plan in those interventions, okay? So we're going to encourage that patient to get up and walk. Okay. Ultimately, the goal is that by using the nursing process and by coming up with a care plan, we minimize errors and omissions in care planning, okay? So we don't miss things. So this gives us a little bit more information. And this is what I'm talking about in your Caputi book on those pages, okay? It's going to give you more detail. So in our assessment phase, it's where we gather information. It's all those questions that you were asking. It's identifying signs and symptoms. It's assessing systematically and comprehensively. It's gathering accurate data, okay? So, for example, one of the questions that was brought up was, I want to know what medications my patient is on. Well, if that patient says, I think I'm on Lasix, we need to figure out a way to verify that, whether it's having the family members bring the medications in or calling a pharmacy to find out the accurate information or calling that patient's PCP. But we need accurate data, okay? And then predicting potential complications. It's gonna take you a little time to get to that, but ultimately, we wanna be able to predict those things. So we go back to the falls, because I said it's the easiest one and it's the first one you're gonna get. If my patient comes in and their gait is off, or I know they've had a previous fall, or they came in for a fall injury, I'm going to anticipate that the potential complication of those things could be that they gonna fall again, or that they could fall, okay? Now there's other assessment data that we collect that could tell us potential complications, but like I said, it'll take a little bit of time to start getting to that point because you still have to gain knowledge, okay? but we do that as part of this stage. Okay? Next is going to be diagnoses. That's interpreting the information that we have, stating our problems and our strengths. Okay? So, what does the patient's falls tell me? Why am I thinking that? We're going to start clustering together things. So, for example, I'm going to come away from the falls for just a second. If my patient came in and they're complaining of being dizzy, okay? They're complaining of, or they have vital signs and their blood pressure is low. I forgot to get a marker. Leslie, can you do me a favor? Can you go get me a marker? If you go to my office, Carla's in there, and just ask her for some dry erase markers. Pretty please. My patient's blood pressure is 100 over 58. That's pretty low, okay? So we already discussed earlier this morning that could tell us our patient may have some, conscience issues, and that it could put them at risk for fall, right? Because it might make them dizzy, they could be dehydrated. All right, so when I start clustering, and what that means is grouping. When I say cluster, I'm going to take all of that assessment data, I'm going to start grouping it in groups and say, okay, so if my patient's dizzy, they have a low blood pressure, low heart rate, those things could tell me that my patient is dehydrated. I could add to that they have decreased urine output. I could add to that they told me they didn't drink anything today. Maybe they're perspiring, or maybe they're not perspiring. Okay? All of that data I'm going to cluster together, and it's going to give me, that's how I come up with my nursing diagnoses. I don't do this backwards. Nursing students often do this backwards. They want to come up with the nursing diagnosis, and then they want to add the things that support it. You cluster first. Okay? I look at my assessment data, what things go together and are telling me something, that there's a problem. Okay? After we do that, what's inconsistent? Okay? In that data, what's inconsistent? Okay? What's out of the normal? What doesn't make sense? Okay? What's important? Is there more information I need to know? If my patient is elderly and they're telling me that they're urinating a lot and they're having burning and itching, what additional data might I want? Does anybody know? Urinalysis. I might want them to go for a UA. Or I'm going to anticipate that the doctor is going to order it, and then we're going to have that data to go along with it, because my patient might possibly have a UTI. And if my patient was confused, thank you. If my patient was confused, that would go with that as well. So we have confusion. They told us they were dizzy. They had low urine output. Oh, their blood pressure was low. So we said this data told us we wanted a UA. We wanted the doctor to do a UA, because possibly all that told us they had a UTI. Okay? But this is a medical diagnosis, not a nursing diagnosis. Okay? Dehydration is going to be a medical diagnosis too. Mm-hmm. But decreased urine output is our nursing diagnosis. Okay.
So what could, because automatically, we would assume UTI. So how do we wrap our heads around to not, so anything with a medical diagnosis, just immediately, those are no nursing diagnosis, correct?
For the most part. There's a couple that are, but nurses treat symptoms. Doctors treat conditions. That's probably the easiest way to figure it out. For the most part, that's how it works.
What's the full meaning of UA?
Urinalysis. That's okay, you're learning. And this is urinary tract infection. UTI is.
Would you inform the doctor of your nursing diagnosis and then he would order the UA? Or
No, more than likely the doctor is already ordering that. We do an assessment. That's the part that we do. Okay? And then the doctor is going to make a decision upon that. And then we're also going to, okay, so what can I treat as the nurse? All right. So, yes, Melinda.
So the nursing diagnosis is usually fairly broad, and the medical diagnosis is usually very specific. Is that another way of looking at it? It's very specific, saying someone has decreased urine output.
So it probably seems that way to you now because we're talking about a specific diagnosis, but not necessarily. Just depends on what it is. There's so many nursing diagnoses. Some of them are broad, some of them are specific. Just depends. I would, like I said earlier, you need to know them, but I wouldn't stress over it. When you're doing them for your care plan, you can look them up. The bigger thing that comes from a nursing diagnosis is our interventions. It's what we use to come up with our interventions. And that's the part that's more important. That's most important. So if my patient has decreased urine output, what am I going to do? And we're going to get to that. Okay, so what else do? We distinguish what's relevant, what's not. So let me add some information here. My patient had a heart rate of 75, a temperature of 98.8. Their respirations were 20. Oops. Maybe they're taking Lasix. Maybe they're taking aspirin. And maybe they're taking penicillin. Hi. Which information is relevant and what's not is what we would look at next. Okay, so Anne told us early that diuretics make a difference. Like it's gonna make them pee. If they have decreased low urine output and they're on a diuretic, there's a problem, right? They should be peeing and peeing a lot. So this is important. Is the aspirin? Not right now, right? What about the penicillin? Yes. Why? Huh? You don't answer. I'll let you answer in a second. I want to see if somebody else can.
Oh, sorry.
Modesta, you had your hand up first.
Yeah, I want to see if you get a UA and they have the UC and then penicillin is an antibiotic. So.
Okay. But they came in on penicillin. This is my clustering, my assessment data. They came in on penicillin. Is it important? Is it not?
It's important.
So you're telling me it's important. Tell me why. Janet.
No. Because if it is a UTI, the medication is resistant to the penicillin.
No. Melinda.
The penicillin could have caused the UTI, like a super infection.
I'll give you a maybe. What's your name?
Margaret.
Margaret.
There's a reason they're on the penicillin. There's an underlying condition that
Oh, okay, yeah. It's telling me there's something going on. That's probably the biggest thing that's going to click in my head. Okay, why are you on the penicillin? Okay?
Also, along with that, if they're already on a penicillin or antibiotic and they potentially have an infection, that penicillin possibly isn't working.
Okay, so it could tell me that it's not working, and somebody over there said that too. But First, I just want to know why they own it. Obviously, they're sick with something. When people are sick, what do they tend to do? Huh?
Become dehydrated.
But why?
They sleep.
Just because I'm sick doesn't mean I'm dehydrated.
They sleep a lot. They don't eat and drink. Right? I do.
They tend not to eat and drink, is where we're going. So they tend not to eat or drink.
And also, if they're on penicillin for the UTI, I mean, that was the doctor diagnosis, and then they're not taking the medicine as they're supposed to, the infection can still be there.
That could be a possibility, but right now, For right now, I'm going to just say, for the benefits of this conversation, because y'all are taking this like way, way further than what we need to, we just want to know why they're on it, okay? The 20 respirations, we'll say, for the time being, it's okay. Confusion? Dizziness? Okay. Heart rate? Temperature? And we already determined that those were important. Okay? So, how much ambiguity is acceptable? You already told me this was on the high end, but we thought it was okay. Okay? If it was ten with the rest of these vital signs, might I be more concerned about it? Yes. Yeah. Because when you put all this information together, what you don't know yet, but what you will learn, is if this starts to rise and the rest of these continue to go down, but if these two start to rise, our patient could be going into shock. Okay? So I would want to have an eye on those things if my respirations were lower. Okay? Comparing and contrasting. Okay? We already did a little bit of that, looking at our information. What do we have? What do we need to know? Okay? Managing the potential complications. So we already talked about them being on a fall, like being at a risk for fall. So we're going to make sure the room is clear. We're going to want to put that armband on, walk them to the bathroom, those kind of things. Identify assumptions. So what assumptions could we make? We already made one. What assumption did we make? Y'all way over here. We still over there. Just pretend, we're going to pretend this isn't here. Nobody told us they have a UTI yet. Huh? We're assuming that they're sick because they're on the penicillin. Okay? We're assuming because they're on Lasix that they should be peeing and that there's some reason that they're on it. So they probably have some kind of medical history, like they have high blood pressure, they have congestive heart failure, they have some underlying condition to why they're on that medication. Okay? Then we have to set priorities. What's most important? And usually here we use Maslow's hierarchy to determine priorities, which the number one is safety and number two is basic needs. Most of the time when we see our patients, they're not going to be higher than that because they're in the hospital. So even though you should know the rest of the hierarchy, most patients fall in the first two. Okay? So just know that. And within those two, we're going to determine what's most important to deal with first. Okay? And then we're going to collaborate between us and the doctor and whatever, like RT. If we had a patient that was having respiratory issues, they're going to have to, do breathing treatments or whatever. We're going to determine who's going to help. We need lab to do our UA. Okay? Maybe our tech's going to go in and help them get the specimen and send it down, and then lab's going to give us our UA. Okay, so that leads us to our outcome and planning, and part of that is delegation. So who are we delegating to? We're going to maybe we delegate it to the tech to get our UA. Maybe, yes, I want another set of vital signs here because that's kind of low. I want to check it, okay? Make sure, is it really that low? Maybe I delegate it to my tech, or maybe I go do it myself. because I want to make sure it's low. I mean, make sure that it's accurate, okay? Or maybe I want a manual blood pressure. Yes, ma'am.
You maybe want to also let them know what to expect with that UA if they're being on penicillin.
Wait, what? I can't hear you.
What to expect in the UA being on the penicillin.
So what do I expect in my UA?
It may be a false negative.
Why?
She's already being treated.
Okay. I'll take it. She's a little ahead of us, but yes, we'll look at that. All right. So, where am I at? So communicating with our doctors, what's going to be ordered, what are we going to delegate to other people, making sure they know that the patient is already on the penicillin. So if we do get a false positive, that or if we get a positive, that they know that that's a possibility. Okay. And then eventually one of our goals and outcomes is going to be teaching, because we always teach. Every time we have an encounter with a patient, teaching should be involved. So if they have decreased urine output, our always number one teaching is going to be what?
Drink water.
They should be drinking some water. It's easy, guys. It's not always this like brilliant answer that you didn't already know. I promise. So basic thing. If you're dehydrated, drink. If you're sick, drink. Because we always need to be hydrated. Like 90% of our bodies is water. And we got to make sure we're getting that. Okay? So, do I have any questions up to now? Do you guys have a good understanding or no, or? Lay.
Yes.
Yay.
So the part where we set priorities, it's still in the diagnosis.
In the diagnoses and planning part, yep. So planning and diagnoses kind of go together. We do our diagnoses and then we prioritize.
Okay.
Okay? Yes, ma'am.
On our test, are we going to be tested over nursing diagnosis?
Yes.
So,
But it won't be, do you know that nursing diagnosis?
Yeah.
It might be what's most appropriate. Like we might give you 3 or 4 and give you a situation and say, tell me what nursing diagnosis
so at that
is.
point, we need to be able to recognize the difference between a medical diagnosis and a nursing diagnosis, correct?
Yeah, but that's going to be real obvious.
Is it going to be?
Yeah.
Some of
Our point is not to trick you, it's to make sure you understand.
Some of the question.
So the question is, will you be tested on nursing diagnoses on your exams? Yes, you might see some nursing diagnoses, but it'll be in relation to a situation. So like maybe I gave you this scenario and I said, what's the most appropriate nursing diagnoses? Maybe I put dehydration, urinary tract infection, decreased urine output. Which one is the nursing diagnosis?
I would have been in danger of picking dehydration.
You might be on the first test, but you shouldn't be on the second test. And you shouldn't be after now because now you learned it. You might have been before because you hadn't learned it. The whole point of now.
I would have picked dehydration because that's something that a nurse could address. She could give her patient fluids. I mean, like
She
something to
can.
drink, something to drink.
But dehydration is a medical diagnosis. And dehydration is one of those ones that kind of sits on the line. And like I said, at the end of the day, guys, this is a teaching mechanism so that you understand. It's a learning mechanism. So you understand the nursing process. In the actual clinical setting, we don't say the patient has decreased urine output. We recognize that the patient has decreased urine output and we intervene. Okay? So it's really coming up with problems. So like at some schools, they don't teach the nursing diagnosis. It's part of the nursing process and it's part of our nursing practice and it's part of almost every state's nursing practice act. So should I know what it is? Absolutely. But at the end of the day, what I need to recognize is that nursing diagnoses are our problems that we intervene with. So if my patient has decreased cardiac output, which means their heart is not pumping effectively, they're not getting blood everywhere, what interventions am I going to implement to address the problem? Okay? Because as a nurse, I can't do anything. I can't, in order to truly address dehydration, The patient has to be prescribed fluids. I can't prescribe fluids. I can administer them, but I can't prescribe them.
Well, but you can educate the patient on drinking more, right?
But once they're in the hospital, 9 times out of 10, they're past the point where drinking is going to be an issue. But part of my interventions is teaching, and I should be teaching them that they should be drinking fluids. So most of the time when people have dehydration, they're coming in the summertime because they're out in the weather and they didn't drink. Or they're old people and they didn't drink because they have lost appetite or something like that. Or sometimes medications make people, like Lasix, people take Lasix and they're not drinking and it's making them pee, but they're not drinking enough, okay? Or some other diuretic, okay? So we always are gonna teach about drinking fluids, okay? Okay.
About the nursing diagnosis. In the book, you have problem focused, risk, and health.
We're going to talk about
Okay.
the difference between them. Okay. Did I have another question over there?
Yeah, I guess my question to that was, 'cause, and maybe you said it, but I couldn't hear it, was what was the answer to that? When you said the problem, what we should be responding to then?
Oh,
It
I'm
was
sorry.
decreased urine output, because that's the one the nurse could intervene at.
Oh, okay, because I was so lost. I was like, wait, what question? You're talking about the test question that I gave, the medical, like the dehydration, the, what did I say, dehydration, urinary tract infection, or decreased urine output? The answer was decreased urine output, because that's what the nurse can do something about.
That's a symptom, not.
Yeah, so most often, nursing diagnoses are going to be some type of symptom or signs and symptoms. And it's a problem that the nurse can do something about. Okay? The best way to think about it is it's a problem that we can do something about, because not all of them are going to fall under sign and symptom, but the greater majority of them are. Okay?
So what exactly would the nurse do besides teaching, since we can't really do anything else? Like when the
So you can administer fluids that are ordered.
But that's after it's been ordered. So we assess the information, we put in their medical record, we let the doctor know, he comes and he or she assesses, and then that's whenever we administer. But right away, we just can't jump in there. Okay.
We can't do nothing
Right.
that wasn't ordered by the doctor. So we go back to, remember the first day when I talked about following instruction? Okay. So most of our interventions, the greater majority of our interventions, are going to be following instructions. Okay. So the doctor ordered fluids, I can administer fluids. Okay. But if you want to talk about something that doesn't have to be ordered that would go along with this particular patient, the doctor does have to technically order fall risk precautions. Some hospitals have gone away from it, but I would implement that. I don't need a doctor's order to put on a yellow armband or to put the star, or sometimes it's a leaf, whatever that hospital's policy is, on the door. I don't need a doctor's order for that. And that is a nursing intervention, okay? I don't need a nursing intervention to say this patient needs a bed alarm, okay? There are some interventions that we do that we can then ask for an order, or depending on the hospital, we can put in the order ourselves.
Depends on if it interferes with patient safety.
Yeah. So those things are gonna fall under the policy of the hospital, because some hospitals say it's a safety risk, so nurses can do it. Other hospitals are gonna say no matter what, you need a doctor's order, but if you implemented it before the order, you wouldn't be in trouble. But that's that ambiguity that you're gonna have to, like, as we go along, you'll learn.
I wanted to ask, just for those test questions that say, okay, what do you do next? So I was just making sure the answer will not always, but if it's for something like that, it would be notify the healthcare provider. Like if it's
My question wasn't about what to do next. My question was about the nursing diagnoses.
No, I know. I was asking it because you were talking about like the intervention, like what we as nurses can do at that point. So
it's gonna depend,
Okay.
because it depends on what choices I put in there. I could have put other choices in there. I could have put in there, let's see, what else could we have done? It could have been collect a specimen for the UA, because that's an order. So if I gave a list of interventions, I could put select all that apply. I know, nursing questions suck. They suck.
Learn that real quick.
So I could put ooh, collect a specimen, administer fluids.
Notify provider.
Yeah, notify provider.
Is it gonna say administer?
Put on a fall risk.
Is it gonna say administer prescribed fluids?
It might say give. It might say give. It'll say give or administer. I mean the same thing. It's not gonna say prescribe. If it says prescribe, the answer is wrong because you can't prescribe. Okay?
But the doctor, okay, see, I'm trying to figure out the wording.
Prescribe means literally I wrote a prescription. You cannot do that.
Okay, so if it, when I say prescribed fluids, I think the doctor prescribed them and I get what.
So that's why now you're becoming a nurse and you're learning and your language is going to change. Because now you understand what prescribe means. Prescribe means I'm writing an order. You cannot write an order as a nurse. Goes back to what I was saying to you guys earlier. Like, especially, it's hard, guys, when you already have nursing experience in the sense of like, I've been a tech or I've been a clerk or whatever. You already have that nursing experience and there's certain things that we already know are gonna happen. We gotta pull back because now we have a scope of practice. We have a standard of practice in which we fall, okay? And those steps is what you're learning. And before you didn't have to fall into that, or the language didn't matter because it all means the same to me. I'm not doing it. Does that make sense? Okay, so I'm gonna correct you just because I need you to understand now what is my scope of practice. What does it really mean when I say prescribe, okay?
Well, that's where I'm getting tripped up on, the questions on Evolve is just some of the language and the way the options are given. So.
Yeah, and all the Evolve questions, sometimes the Evolve questions suck. I mean, all nursing questions, no matter what book you read, guys, no matter what book you use, there's gonna be a question that's a bad question. We're gonna have test questions that are bad test questions. Do you know how many, for NCLEX, there's literally almost a year process before a question, between when a question is developed and when it goes on the test as a pilot. Not even a question to use, a pilot question. Because it's written and it goes through like several steps of evaluation. Is it written properly? Does it have the right language? So on and so forth, okay? It's not just a bam and bam.
So the test 10 years ago was only asked about 10 questions?
No, because it used to be pen and paper. So just know, no matter what resource you use, you may have bad questions, okay? And if you have a question about a question that you're asked, write it down and bring it in, okay? Take a picture. I have students that literally, and I'm not saying do this on every question, but I have had students that make screenshots and they email them to me and say, Miss Addison, this question, and that's fine. That's fine, okay? Just know, I mean, I can answer those questions, but just understand, like, I can't, like, guys, like, I can't study every question with you, okay? So if there's one that's really tripping you up, send it to me, okay? Or bring it in. Okay, you are Elizabeth. I gotta write this down.
Competency, where do we access these diagnoses, like a list, or like when we do our clinicals, how are we supposed to come up with nursing diagnoses that are appropriate?
You have a care plan book?
Yeah, I think it's in that book.
It says all-in-one care planning. Yeah, you might want to, or at least borrow. Tell somebody to bring it to clinical and see. But also, if you Google NANDA, because all nursing diagnoses come from NANDA, Google NANDA diagnoses, and it'll give you a current 2020. Now, because I used to hand out the list and then I figured out students weren't paying attention to it, so, or not to the list, but you have to look up the nursing diagnoses. You can't just pick them from the list. So you'll find a PDF and it'll say 2019 or 2017 to 2020, I think is the current list. And it'll give you a list of every single nursing diagnoses. But the nursing diagnoses have definitions. So you have to look them up. So right now, if you were to Google, and I did it this weekend so I could tell you accurately, if you Google the NANDA list, I think it's Nurse Labs that comes up, and where you can see the definitions and the defining characteristics. So you'll get a definition for decreased urine output. What does that mean? What are the characteristics or signs and symptoms that tell us a patient has decreased urine output? Oh, and then the fun part is, they'll give you interventions that usually go along with it. It becomes a cheat sheet. This isn't, I mean, there's a standard of practice. So all of us should be coming up with most of the same interventions, okay? So it's not to trick anybody, it's a learning process, okay? And you'll start to see that a lot of them overlap, and the nursing diagnoses are no longer gonna matter, because at the end of the day, what are we treating? What do nurses treat? Which is ultimately, what did I say? It's a problem. We're treating a problem. So the patient has shortness of breath, and shortness of breath is also a sign or symptom. The patient has decreased urine output, which is also a sign or symptom, okay? So that's what nurses do something about, okay? Natalia.
Yes. There is a NANDA list in our book of
It's a short one.
Yeah, that's not an exhaustive list. Okay, it has some on there.
general idea of like
Yeah.
to get a
So it does, and there are some in your book that are going to be defined in your book, but the better resource is going to be your care planning book, which isn't going to have them all in there either, but it's going to take you by system and try and explain to you how we come up with them. But if you want an exhaustive list and the ones that are going to be like, because not everyone is in your book, when you start getting outside of your book and understanding it, go look up the NANDA list and find the definition. Huh?
Is there an app?
Is there an app for that? There probably is. There's an app for everything. But I didn't look at the app. I just know that when I Google the NANDA list that I can get that, and from that, I'm gonna look for the definition, because if you put it on a care plan and it's not appropriate, you're gonna get it wrong, and you're gonna be like, well, it said blah, blah, blah. Well, did you look up the definition, and does it apply to what's going on with your patient? Okay, so it's not just I picked a diagnosis just to pick it. You have to understand, why did I pick it? What does it mean? Does my patient have the cluster of symptoms, which is our defining characteristics, that support me saying that they have decreased urinary output or decreased cardiac output or risk for falls? Okay, does that make sense? Or do I have any questions? Okay. Any more questions? Everybody feel comfortable or kind of comfortable?
Could you do like anticipate, like you can't give an IV or like do orders, but you could anticipate that you're going to need a UA, so you go ahead and be like, since there's a decreased urine output, you kind of watch out for like, hey, let me know if you need to use the restroom so that I can go ahead and collect that urine instead of.
So am I going to anticipate certain things that the doctor is going to do? Yes, very much so. So remember when we were talking about in our interpreting or our diagnoses and planning phase, we have identifying assumptions. Because remember, this book, I'm telling y'all, it's gold for you. It's really helping you to understand what we do in each one of those steps. So an assumption that I'm going to make, and you made a very good one, is that my patient's going to have a UA ordered. So am I going to anticipate that I'm going to need a urine? Yes. And I will tell you right now, okay, so again, I'm going to go back to, guys, this is going to be really hard for quite a few of you in this class who already have medical background, especially my people who work at the ER, because I got some that work in the ER in here. There's a lot of stuff sometimes that we do in practice before we get an order, because we're anticipating something's going to happen. Okay? So on the back end, what you're not knowing right now, maybe, that you now are going to learn today, is so maybe I work in the ER. Are you one of my ER guys?
Yes.
Okay. So when we go in a room in the ER, the first thing we automatically do pretty much with every patient is we put in an IV and we draw labs. We take all kinds of tubes. We may not even need them, but when we put in an IV, we take blood because it just makes sense because we're already doing it. And I don't have to go back in and do it later. Okay? But before those tubes of blood can be sent down to the lab, a doctor has to order the tests. Okay? So sometimes we anticipate those things coming through, but nothing can be done with it until a doctor puts in an order. And sometimes there's some things that we can't anticipate. We may anticipate them being done, but we can't do. So for example, this is a bad example, but I'm gonna use an EKG. Not all patients who come in and complain that they have chest pain are gonna get an EKG. The greater majority of them are, but that's depending on the hospital that you're working at. You can't just do an EKG on a patient. Now there's some hospitals where that's just, especially in the ER, we go in the room and we go through it. Okay, and the doctor's gonna order it later. And like I said, guys, that's a bad example because 9 times out of 10, we're gonna do it. But there are those cases where they're not, okay? So there's some things that first we're guided by what? Do you guys remember from last week? So always first, our standards of practice as nurses, our Nurse Practice Act, then our hospital policies, okay? So we have to know what our hospital policy is. In some ERs, Stephen as the tech can put in a catheter. In other ERs, he can't. Even as a nurse, there's things that I can do. So for example, when I worked at Parkland, I could draw ABGs as a nurse. When I worked at JPS, I couldn't. RT does it. Or respiratory therapy for those who don't know what RT is. So even though I have the skill to draw ABG, the hospital policy at Parkland says I can do it if I'm an ER nurse. The hospital policy at JPS does not allow me to. Maybe the hospital policy, or I should say the hospital, oh goodness, my system is what I'm saying. So the hospital system, if I work in the ER, I can draw ABGs, but maybe when I worked in the clinic at JPS, I couldn't. Okay? So do you guys understand, like, you have to know what your policy is, what you can anticipate, what things you can do and what you can't? When I was at the clinic, there's a whole bunch of stuff when I worked at Stop 6 as the team lead that I couldn't do. And I was an ER nurse and I'd be like, but you can't do it. I don't even have the supplies to do it. They don't even give you the stuff to do it because they want to make sure that you don't do it, okay? If somebody comes into the Stop 6 to see the doctor and they're having chest pain, I have to call the ambulance. We're gonna make sure they're stable. Like if I needed to do compressions or something, I would do that. But I have to send them in an ambulance to the hospital. We would not intervene as an ER nurse, okay? So I have to know when I can do those things and when I can't. And it comes back to learning what ambiguity can I give in situations, okay? So I know that was kind of a complicated answer because it's pretty much, you're gonna figure it out. It wasn't a yes or no, but I hope it answers your question. Yeah? Maybe?
Yeah, I think so. I think as a tech, you try to be helpful a lot of times, or you get used to doing certain things, but you don't realize like what is what's too far. Like on Tower 10, we send the labs for the year, and then when we're with a patient in the ER, I can go get the cup and make sure that I get it for them, but I'm not allowed to send the lab, so like things change.
So that is a great example of what I'm saying. Depending on your hospital policy, what unit you're on, what role you have at the time, you may or may not be able to do certain things, okay? So that can change. But your skill level as a nurse doesn't change. Can you do that as a nurse? Absolutely, okay? And now you're having an understanding of what you do as a tech. Okay? What am I doing that's actually above and beyond my job? Like, I could tell the nurse to go kick rocks if I feel like it, because my job is very much task oriented. It's not to analyze anything, it's not to make any assumptions. Do I love you as a tech when you do that? Absolutely, because it helps me. I want you to do those things. I want you to tell me if my patient's skin looks like it's gonna break down, because those things help me, because you see the patient a lot more sometimes than I do, okay? But what is our scope of practice? What am I supposed to do as a nurse is what you're learning now. Okay? Good questions. Okay. And even Miss Ann up here, who as an LVN, there's quite a bit of stuff that she can do because she's a nurse.
She's a nurse.
So let me explain that nurse, the title of nurse, belongs to registered nurses and registered nurses only. In Texas, y'all call a whole bunch of people nurses that are not nurses. I am not from here, and in Illinois, if you do that, somebody will curse you. Oh, I'm so not kidding. It is law. It's law here, but it's law. And in Illinois, they don't play that. Here, y'all, like, it was beyond me. Like, I go to doctor's office, and they're like, my nurse. You got a nurse here? Because registered nurses don't work in doctor's offices a lot of times. But they refer to their MAs as their nurse. That's not a nurse. It's a medical assistant. And they don't have a scope of practice. They don't have a license. But can they do everything the doctor teaches them to do? Yeah, because they own his license. And he becomes responsible for it. Okay? But as an LVN, there's things that she has done that has been task-oriented. So the nurse delegated to her, the registered nurse delegated to her to do that she just did. But now, as a registered nurse, she will do the assessments and make the clinical decision behind those tasks that she has done as an LVN. And most LVNs already understand a lot of that, but is it within their scope of practice? The answer is no. And honestly, guys, I know some LVNs that are better than some RNs because they've been LVNs so long. And years and years ago, they got to do more than they do now. Okay. All right, so we are at our implementation phase. We kind of already talked about it, but I want to make sure you understand it. Implementation has to do with our interventions. What are we going to do? Okay. We're going to put on that fall risk band. Where maybe if our patient is immobile, we're going to put on SEDs, which are sequential compression devices that pump their legs so that they get good circulation. Maybe it is frequent toileting. You know, any of those things are going to be interventions. Anything the doctor orders for us to do is going to be interventions because we're going to follow those instructions. We get lots of those, so it's important for us to learn how to follow directions, okay? And then finally is going to be our evaluation phase, okay? And evaluation is our reflection. So remember earlier, and on here, you'll see under reflecting, evaluating data is one part of it. So looking at what we have, what do we need to do about it? And so we already did quite a bit of that, right? We looked at the data. What does it mean? What do we have to do? So remember the first thing I said about this is even though it's a sequential thing, we do them at the same time, or we have pieces of it intermixed. Thanks, huh? Like it becomes this cyclical thing. Like the picture. That's why all those arrows look funky. It wasn't just because, it's because we do pieces of this throughout, okay? We're constantly assessing, because, for example, okay, so if my patient went to the bathroom, so we went and did that UA and collected the specimen. When I'm collecting the specimen and I look at the urine, I want to look at it to see what the color was. Is there something in it? Is it cloudy? Is it clear? Does it have sediment in it? Does it have blood that I can see? in it, that's assessment. But I was also doing an intervention because I was collecting the urine, right? So those, it's a continuous circle of thought and action, okay? All right, so then evaluating and correcting thinking. So we've done some of that as we were talking, right? We have to correct our thinking about something because maybe we thought it was this way, and now I have to correct my thinking so that the next time I do it correctly, okay? Or maybe I catch the patient earlier who's a fall risk, okay? Because I didn't realize or I didn't think about previously that a patient who came in because they were alcoholic and they were unruly, that they would be a fall risk. But now I have a correction in thinking, and now I know, oh, okay, that's somebody I would consider for a fall risk as well, okay? So, nursing process is the foundation of what we do, guys. Do I have any questions? Any more questions? You guys ask good questions, by the way. No? Everybody feels good?
I have a question. On the evaluation, when you do all that and you get to the evaluation and then something is off, do you go back and start all over the process?
Okay, so I'm going to ask you to answer your own question.
Yes.
Yes. And why? Why did you come to that conclusion?
Because I have to, the mistake maybe started at the initial assessment, so I have to reassess the patient.
Mm-hmm. And what is...
make a right diagnosis, maybe because if I didn't analyze the cluster of information that I have.
You got to talk up because they can't hear nothing you say.
I could make a wrong diagnosis, so I have to go do the reassessment and make the right diagnosis so that I can do another planning to implement and reevaluate.
So her first question was, if I get to evaluation phase and recognize that maybe I had a wrong diagnosis, or maybe, I don't want to say wrong diagnosis, but maybe there was something that I missed and I need to add an additional one, or I need to modify my interventions. She said, do I go through the process over again? So I asked her the question back. And I will do that. I told you, I want you to think, because we already answered the question, right? But you have to process it in your mind, because it does take time, guys, to learn how to think like this and to change, to think through it. So if it's a continuous process, I'm continuously doing that, always. So you're not going to have one time when you do it, and that's why I changed how she worded the question. She said, what if I got it wrong? Well, what if the patient meets the goal? Then we reassess. Is there still something we need to work on? Have they met that goal? We're constantly reassessing and intervening and deciding that, hey, they met that goal, or they already did that, or maybe we need to change this. It's a constant flow of cycle through the nursing process all the time. We're constantly thinking through this process. And when you get to Leslie, because Leslie hasn't been a nurse as long as I haven't been a nurse as long as some of the other people here, this process is gonna go through your head so quick, you're not even gonna think about it. You're gonna go through the steps like this. But right now you're learning the process and how to think like this and what questions to ask, which is why I told you this book is helpful and why we chose to add it, because the rest of this chapter literally goes into each one of these steps and it tells you some of the questions that you should be asking and some of the things that come under each step for you to be thinking about, okay? And you should be taking that to clinical each week. Okay? So, it gets easier, you gain more experience, and then these things start to make, you get to conclusions quicker and you implement things differently or interventions quicker or know where they fall in there. Does that make sense? All right. Do I have any other questions about the nursing process? All right. So, we just talked about this. The nursing process is continuous and overlapping. My example was when performing an intervention, such as changing your patient's dressing, we should also be assessing their skin. Okay. Is the current intervention that we're using to address their wound, is it working? Is it healing? So we're assessing while we're intervening to change their dressing. So, we already went through this. This is just a quick review. Assessment. I need you to know the difference between subjective and objective. That was one of our objectives, right? For this unit in your SID. Yeah? So, subjective is what I can see. Sorry, what the patient tells you. Subjective is from the subject. There we go. What the patient states. Objective is what I can see. What I can see, what I can hear, what I can smell, what I can touch, what I can obtain from attaching a machine, and it tells me the vitals. It's fact. Okay? Everybody understand the difference between the two? And not mess it up like I just did. Subjective is from the subject, from the patient. Okay? Secondary resources. So when I have a patient that cannot speak for themselves, Natalia says, we're going to ask the family. They're going to be a secondary resource. The other part that goes along with that are secondary resources, do you remember me talking about doing what we call a medication reconciliation? So when I ask a patient about their meds, what they're taking, it's called a medication reconciliation. We are looking to see what medications that patient has. Does it match what I have in the computer, or maybe I don't have anything in the computer because they're a new admin and I need to put it in. Okay? So another secondary resource to that would be our pharmacy. Remember I said we're going to call the pharmacy or we call the doctor's office. Maybe we request records from those places. That's the secondary resources. That, yes.
On that medical reconciliation, if the patient has medications that they take at home, they haven't been prescribed at the hospital, so they're not matching, do you let the provider know there's something missing?
So I'm confused. Why wouldn't it be on the?
If medications don't match, what they've been prescribed at the hospital doesn't match what they take at home.
So the first medication record comes from what the patient tells us they have at home. That's what we're matching our records to.
Do you automatically put those orders in as something they're going to take at the hospital?
Okay, so you're going to answer your own question. Do you put that in as something they're going to take at the hospital?
I would say no, because
why?
Because I can't put a medication.
There you go. But are you going to put it in the computer?
Yeah.
Yes, because it's part of what we assess as the nurses. It's part of the data that we collect in our assessment phase. It is included in that. What medications are they on? What's their family history? What's their medical history? What surgeries have you had? Do you smoke? Do you drink? Do you work? Who do you live with? What do you do for work? What religion are you? All of that is part of our initial admission assessment.
You're just reporting the medication as information. Do you bring it up to the provider if the medications don't match what they're taking at home?
So if there is a computer system, it's automatically going to flag that it doesn't match. And so I hesitate because you're kind of getting a little bit ahead, because when a patient comes in for admission and I ask them what medications they're taking, it's not going to flag anything. You're not going to know that something doesn't match. Because I feel like what you're asking me is if their medications don't match to what's prescribed in the hospital, and that's not what we're looking to match.
Okay. Well, maybe there's an important medication they take at home that they need to take at the
Right, but that's what I'm saying. A medication reconciliation has little to do with what's prescribed in the hospital, because those prescribing in the hospital comes after we do a medication list. So when I admit you to the hospital, I'm going to ask you, what medications do you take? Now, when they leave, then we do another medication reconciliation, because the doctor might say, Maybe we were giving you Lasix IV while you were in the hospital, but I'm not gonna send you home on Lasix IV, okay? Because maybe you were already on oral and we're just gonna keep you on oral, okay? Maybe he stopped the penicillin and he's gonna give, that's what I had in my head, but that's not right for a UTI. But anyways, different antibiotic. That's when my medication reconciliation has to match up, is on discharge, is when I would be concerned. Because I want to make sure whatever the patient is going home on is whatever list I'm sending them home with is what was ordered. Those lists match up. What was changed when they came into the hospital. Okay? Does that make sense? The other time that it might be an issue is when you have patients who maybe they're seen in the JPS network, okay? And their PCP is in JPS, they're now being in the hospital, and what they're telling you that they take doesn't match our list in the hospital because they are a patient of the system. Then those lists might be an issue where you might see them not matching up. Okay? Does that answer your question?
Yeah, I guess you would just let the provider know at that point.
Yeah.
But it was involved. I guess
it's always going to be important, but like I said, if you have a electronic system, it's going to flag it. If you work in the clinics, then you're always going to flag it, but you're not doing it anyways. In the clinic, the MAs do the medication reconciliation. I know that's really crazy though, but all they're doing, literally, is putting in the list. Okay? Good questions. Y'all want to be graduated already. But I will tell you that's normal for nursing students. It's important though that you get the steps in between, and that's why I keep stopping you guys and saying you're getting ahead of yourself, because if you miss these small steps in between, you're gonna miss things. You're gonna miss small safety stuff. You're gonna miss the basic nursing that we do, because we don't always just, when a patient comes in or they're complaining, we go back to the dehydration. The first thing we do isn't put in an IV. The first thing we want a patient to do, unless they're already at that like extreme level, is drink. I told you all I work nurse triage. If somebody calls me and I'm gonna tell, drink some fluids. Go to the store, get some Gatorade, get some whatever all those drinks are called, Powerade, blah blah blah, and drink that to replenish your electrolytes and your fluids. Okay? You call me and you tell me you have a kid who has a fever and that's sick, we're gonna say push fluids. Anybody who's sick, push fluids. Okay? It's not gonna be go to the hospital so we can hook you up to IV. But all of you as new nursing students, the great majority of it, are gonna say, give them an IV. Because your mind is gonna go to the bigger interventions first. So you have to make sure you don't miss those smaller ones. Ask questions, identify patterns, okay? You're gonna learn about trending vital signs, okay? Or patterns of things happening, okay, that are gonna be important. Making inferences is the same thing as making assumptions. Okay. And then we're gonna interpret and validate data because we want it to be accurate. We talked about that. Okay, so then, going back to where we started, which was the critical thinking, we're going to apply the knowledge from our prior sciences. We know that the heart should work this way. We know that breathing should work this way. We know that that bone should be there, is that I'm using as a landmark so I can give this injection. Bones don't move unless they're removed. Okay? But the bones and the skeleton is the same in everybody. Okay? All right. Oh, and our professional standards. All right? So we already talked about this. This was my give you guys an example. We already went through the example about the car. Okay? We talked about diagnoses. We talked about how we use the Maslow's hierarchy. Okay, so nursing diagnoses can be an actual problem, which means the patient is experiencing it now. My patient is does have an infection versus my patient is at risk for infection. Okay.
On the assessment, it's Gordon's 11 patterns of something, it's in the assessment check. The
Okay.
nursing process. It's just one of
The
those
functional health patterns.
Functional
This
health
little box.
patterns. You need to memorize those 11 functional health patterns.
Memorize them as the 11 functions? No. Know that I need to ask about those things? Yes. So like when we do an assessment of a patient's sleep, we're going to ask, how do you sleep? What time do you go to bed? What time do you get up? Do you watch TV to go to bed? So what you want to get good at is asking questions.
Questions that revolve around these patterns, right?
Yeah. I'm always going to ask about the pattern. Okay, but I don't have to remember those 11 functions because they're going to be part of your assessment anyway. They're all included in there. So then the next type of nursing diagnoses is going to be teaching. What did they call it in your book? They call it something different. But readiness to learn or something crazy like that is your teaching diagnoses. Yeah, those are your teaching diagnoses. So I have a patient that comes in, they're diabetic, and they're not taking their medication. We know that they're chronic diabetic and they come in. Their nursing diagnosis might be readiness to learn about insulin or learn about their medical diagnoses. Okay. And nursing diagnoses change. So we've talked about how this process is constant flow. All right. Do's and don'ts. Right diagnoses for problems we are licensed to treat. That's the difference between medical diagnoses and nursing diagnoses. Okay? I cannot prescribe. I cannot write orders. So, therefore, it can't be a diagnosis that I put. There's a label and an etiology and signs and symptoms in all actual diagnoses. I'm going to post these. No, I'm just telling you. So you don't have to waste all your your data space. I'm going to post them. I posted the ones from last week. Yes. So if I have, we're going to take this example I have up here. So I have decreased urine output. Related to does anybody have a book? I'm gonna have to look it up. Hold on. Cause just like I told you, no, the care planning book. I'm looking for my phone. Okay, so I'm gonna look it up. I'm gonna Google it because I don't know what all the definitions are and I don't want to tell you inaccurately. So if we look up nursing. Do y'all need a break? I see a whole bunch of people getting up. Okay. Nursing diagnoses, decreased urine output. So urinary retention is what this one is about. Body's failure to effectively and completely empty the body. So, related to factors. an enlarged prostate, general anesthesia, inability of the bladder to contract adequately, inadequate intake. Remember we said our patient had dehydration? So we'll say for our patient, because were those other things appropriate for this patient? No. And I don't have to write down every single one of these. I'm going to write down what's appropriate for my patient. The next one is infection. Is that appropriate for our patient? Yeah. So we're going to write related to infection and inadequate intake. Then we're going to have our as evidenced by. And that is our signs and symptoms. So the other thing that would have needed, we said a UA. The other lab that would have been ordered was blood work. So our CBC and our CMP, comprehensive. So I'm going to get a white blood cell count. So as evidenced by an elevated, because white blood cell count, or if it was in the UA, then you might see white blood cells in your UA. Or I could put, if we were just talking about the UTI, if it was that, we could say abnormal UA. Make sense? And decreased urine, or if to be more specific, we expect our patients to go at least 30 milliliters or 30 cc's. Is that the same thing? Yes, because we're all learning our conversion. So what does that add up to in 8 hours? 3 times 8 is 24. So 240 in an 8-hour shift is what we expect. So maybe they have urine output less than 240 in 8 hours. Okay?
Characteristics of the urine.
Okay? She wants me to put characteristics of urine, cloudy urine, stinky urine. It smells, has odor. And the first time that you smell urine that smells, you won't forget it. Okay? What else? Input of less than we'll say less than 200 cc's or milliliters because they're not taking in fluid.
Is that whole thing the nursing diagnosis?
Yep. It's your full nursing diagnosis statement. Yes, Lee.
And do we add the related to and the as evidenced by after we after the doctor has ordered the urine analysis and everything? Because when we make our nursing diagnosis, we don't know.
So the only one here that you might not have is this. The rest of this you would know. I could see cloudy urine when I take my urine sample. I can smell it. I know what my patient is taking in and putting out. So you may not have the abnormal UA when you write your nursing state, but the rest of this you would have.
What about infection? Yeah, just to have infection without the abnormal UA.
Well, we can take that out too. Maybe I can do that. I go with what I know. You guys, most of the time when you're doing this in clinical, are gonna know that because your patients are already gonna be at the hospital. So, and you're gonna be doing this retro, like after.
So you wouldn't put infection unless you had an abnormal UA, not
Yeah, right. You would have an actual diagnosis of some type of infection if you were going to put infection up there. Okay. Now, oh, go ahead, Lay.
Okay, say you didn't have you didn't know about infection and the second thing that we took out. When you find out about those things, do you go back and?
Can you add it?
Yeah.
Can you?
Yes.
Yes. And why can you? Based on what we talked about this morning, why can you? Or why would you?
Aren't you always like reassessing?
Yeah, because this is a continuous process. So as you learn things, you're going to add. Okay. And it's all part of the critical thinking, which is why you guys, I ask you questions back and not just tell you. Okay? It's not to make anybody feel any certain way. It's to get you to think. Okay? Not a lot of times you already know the answers to questions that you ask me. It's just thinking it through. Okay?
So on the risk diagnoses?
We didn't get there yet.
Oh, we didn't get there yet. Sorry.
We're coming. Okay. So, everybody understand the actual diagnoses? Do we have any questions? You're going to get more of this in clinical. All right, so risk diagnoses are different. They don't have the as evidence by part. They just have the related to part. So, my patient is at risk for falls related to prior falls. That's the easiest one to do. Or related to confusion, or related to altered gait.
Would you add all of that or just one thing? Like,
I can put all of it if it all applies.
okay.
The more I got to back it up, the better it looks. But don't be giving me no paragraph. But we want to, everything we do as nurses has a reason, has a rationale is what we call it. So when I put on, so if I say my patient is at risk for falls related to prior falls, what's my intervention? Name 2 interventions we've talked about today.
Wristband.
I'm gonna put on a wristband and a bed alarm. So my rationale is what? Huh? A yellow band tells us all that they're at risk for fall, so that means we're going to do all those extra things like help them to the bathroom, or if we see them walking in the hall and they look, we might run a little quicker, right? To help them. So the yellow wristband tells us they're at risk, and the bed alarm tells them and us that they're getting up. Don't get out the bed until somebody can help you. So that's our rationale. And our rationales come from research. Okay, that's our evidence-based practice. So when it's asking for rationale, which you should always have on your care plans, it's going to come from your book and you're going to reference. Okay, it's going to come from your actual book or it's going to come from your nurse care planning book. And in general, that is where our rationales always come from. They're going to come from the nursing-based evidence research that we have used to establish nursing standards of practice.
Just to confirm, you did say that the risk diagnosis don't have the related to.
No, they have related to, not as evidenced by.
These diagnoses do not have defining characteristics or related factors. Because they have not yet occurred.
Yes.
Is that different?
Yes, Evolve does say that. Even
So,
even on the quizzes. That's one of the questions.
So in the book it says...
so the etiology, it has a cause. That's your related to factor, is your cause.
But for the
It doesn't have defining characteristics, because your defining characteristics is your as evidenced by, is all those signs and symptoms, because they don't have that. But a risk diagnosis has an etiology. It has there's a reason why we're saying they're at risk for it.
So related to factor and related factors are different?
In that context, I'm thinking they're saying that the related factors are their defining characteristics, because that's in the same sentence, isn't it?
These diagnoses do not have defining characters or related factors because they have not yet occurred.
They're saying, my understanding of that sentence is they're putting it together as the same thing.
Okay.
Like related factors or defining characteristics is the same thing. So sometimes when you Google it, instead of defining characteristics, it'll say related factors.
Okay.
Your etiology, and you see I have it up there written differently, but this is how we write the statement. So your etiology is your cause. I'm saying that they're at risk for falls for a reason.
Gotcha.
And so that's my etiology. You're at risk for falls because, oh no, that's fine. This is learning. God, do you know how long it took me to figure out how to teach this stuff? Let alone, you know, I was in your seat one time and having to learn it and figure out how to write it. All right, so any more questions on that? The readiness for ones, the education ones are written like this too. They need the teaching because, okay? But there's no defining characteristics. There's an etiology, there's a reason why they need that teaching, okay? And sometimes it's just because maybe I got a new diagnosis and I just need to know the information about what it is, or maybe I have a lack of information about it, okay? My patient is diabetic and maybe they're doing everything for their treatment, but maybe they didn't remember or nobody ever told them that they should be doing regular foot care and checking their feet and always wearing shoes, okay? So there's a need for teaching there, okay? All right, so we got to flick because we over our time on this. We had 2 hours. We didn't bypass our 2 hours. So no, I have to keep us on the time to make sure I get through everything. All right, so we talked about the planning stage includes our goals and outcomes. So we have a goal for our patient. The patient will, we talked about walking earlier with our surgical patient. The patient will walk to the nurse's station twice a day, or well, maybe I should put it in feet. Patient will walk 25 feet twice a day by the end of the week, okay? So my goals have to be specific, realistic, attainable, measurable, and timed. My patient has to be able to do it. It has to be specific enough. I have to be able to measure it. I can measure 25 feet. I can measure 2 times a day. That's the time. And by the end of the week, that's another way of time, measuring the time. Okay? And is it attainable? Now, if I said today is post-op day 1 and you're gonna be able to walk to and from the nurse's station twice in this hour, is that attainable? For not for most patients, okay? And it's not realistic and it's not nice, okay? So, keeping it real. We focus on determining appropriate goals or expected outcomes for a patient based on the nursing diagnosis you've already formulated. Specific behavior that shows the patient has reached the goal, criteria for measuring that behavior, the conditions under which the behavior should occur, and a time frame for when the behavior should occur. There's independent and then there's collaborative. So there's some that the patient does by themselves. There's some that we have to help them with, or maybe there's another department like PT, which is physical therapy, or RT, which is respiratory, or OT, which is occupational. And occupational therapy, the difference between occupational and physical therapy helps me with moving my arms, my legs, my body. Occupational helps me with my activities of daily living. I need to learn how to brush my teeth again. I need to learn how to walk the stairs to get on the bus, those kind of things, okay? Keep in mind that all interventions are actions that you, not the patient, will do. So interventions is what you do. Goals is what the patients do. And we already talked about using evidence-based practice. We continually reassess, we communicate, and we document document everything we do. If I gave you a blanket because you cold and got the chills, I need to document it. I know that sounds really stupid, but when you get in the habit of doing it, when you get brought before the judge and they say, oh, that patient had a fever and you didn't do anything, but really you gave them a blanket, or maybe you put an ice pack on the groin because an ice pack on the groin helps bring down fever, but we don't think about those things because those aren't invasive things. Can't nobody say you didn't do nothing, because you did do something. We did intervene. That's still an intervention, even though it's not invasive. Okay? And then we evaluate constantly. All right? And so when you're writing your evaluation statements, we evaluate either our patient met the goal, they partially met the goal, or they did not meet the goal. And then we say we need to continue the goal, or the goal was met. So there's two pieces to that. Okay? So keep calm, and we continue to learn how to think like a nurse. You guys will hear me say that all the time. Nursing students are anxious. Nurses are type A personalities. We tend to be anxious in general about everything. And I don't mean anxious like the patients we get in mental health. We're just like, okay, I gotta do this. I gotta do that. Oh my God, oh my God, oh my God. I cannot tell y'all how many emails I got over the weekend. Y'all be cracking up laughing. And just because, and it's not a bad thing. Like, I expect it. And my answers, I hope, are usually calming, like, okay, it's okay. Just, it'll be all right. We'll give you everything you need. So I like to remind people of that. All right, and so we already talked about all that. Any more questions? We good? We can move on to the next thing? Okay. All righty. Y'all can take a 5-minute break. Patient safety and quality. On the first day of school, we went through that list of things that you learned. Does anybody remember what the number one thing on the list was? Yes, you should follow directions. I'm glad you took that as a takeaway.
Is it from Joint Commission?
No. So on page 2 of your SID, there's all these concepts that you learn for the semester that you're going to get evaluated on. And the first one of that is safety. So it's one of the number one things that we do in nursing. And we always pay attention to. So you heard me talking about falls. That falls under safety. Okay? So healthcare provided in a safe manner and a safe community environment. Remember Leslie was talking earlier, she was like, environment. And I said, we're going to get to it. Is essential for a patient's survival and well-being. A safe environment reduces the risk for illness and injury and helps to contain the cost of healthcare by preventing extended lengths of stay at the hospital. Anybody know what the number one reason that patients have extended stays at the hospital? Margaret.
Picking up a hospital infection.
Oh my gosh, a healthcare acquired infection. Whose fault is that? It's ours. Okay. So we have control of that environment, and are we maintaining that environment so we can keep our patients safe and not add to those costs? Let me give you some food for thought when it comes to costs. When we have those costs, guess what it ultimately affects? Why do you say that, Melinda?
Because that's where the money comes from. So we're not, somebody's got to pay for it, so it's coming out of our raises. And
So it comes out of what we get paid. It affects the supplies that our hospital can get, the technology that we can get. So it has ultimate outcomes for how we can give care and how much we can get paid.
Also, how much the hospital charges the insurance companies.
Huh?
Also, insurance premiums, how much the hospital charges the insurance companies to try to recover some of the costs, right?
But when things are our fault, insurance won't always cover. Like if something
Yeah.
falls.
Right, but so then they tend to start.
So it can
Prices
affect the patients, but not as much as it once could. With the Affordable Health Care Act, those things have a lot less impact than they once did because they can only charge a certain amount for certain things across the board. That's why doctors get mad now. because if I do a knee surgery, I'm gonna get paid $10,000 for that knee surgery, period. Okay? So it's important that the things that we can control through how we care for the patient, that we do so. And that we maintain the patient's functional status. I've been at the hospital and we had a patient come in walking for a routine surgery, and he walked out not able to walk. And it was because of errors that were made by the medical professionals. We want to increase a patient's sense of well-being. Something as simple as taking a shower can make a patient feel better. So remember those basic, simple nursing things that we talked about? Just bathing, giving them clean sheets, making sure they can brush their teeth. Those are all basic things that would be a part of that. Give me 1 second. Oh, yeah.
Tea? I mean, more hot water, but
Like the pink.
the pink stuff.
No, what do we have over there? Snap. All right. All right. So, all right. What else do we have to do? Gotta get back on my train of thought. It's the responsibility of healthcare organizations. We have to foster a patient-centered culture of safety. So, how do you think we foster a sense of a culture of safety? Teamwork makes the dream work. Who is included in that team? She said the nurse, the doctor, the techs are. So everybody who works, yeah, so environmental services, because if we ain't got no clean room, guess what? That's like number one in the environment, right? We need clean. But who else is included in that? That we, huh? Yeah, you gotta say it out loud. You can't mouth it to me. But yes, our patient. So how does our patient become part of that safe culture? What do we have to do to make them a part of it? Patient teaching. It's important, guys. Every encounter, patient teaching. Okay, so continually focusing on performance improvement endeavor. So one that you all can focus on right now that you're learning is medication safety. Making sure we do the 6 rights every time. Is it tempting not to do? Is it tempting not to do, Leslie? We get busy. Yes, it's tempting not to do. But guys, I'm telling you, the day you miss it is going to be the day that you have a mistake. It's not a matter of if you're going to make a mistake for any of us, it's when. Okay? Even when we're doing something to the best of our ability, we're going to make a mistake. We're human. But we want to try to decrease those mistakes as much as possible. So if we start out with good habits and maintain good habits, the less likely we are to make mistakes, and how often we make those mistakes, if that makes sense. Okay? We want to provide and make sure that if there are new technologies, that we understand how to use them and use them correctly. Okay? So if we have a new glucometer system, or we have a new IV system, or whatever the new technology is, that we know how to use it and use it appropriately. Okay? We always want to make sure we're implementing evidence-based practice. Okay? And then having a safe environment atmosphere. So like cords on the floor, things like that. Depending on what classroom I work in, I'll tell students don't put backpacks like in the middle aisle, because as you guys see, I walk. This classroom, I'm kind of confined a little bit more, especially today because we're recording. But you see me walk all over the classroom, and I don't want to trip. I already told you I'm clumsy. So we want to keep things out of the walkway as much as possible, keep our patients' rooms clean, keep lines from being tangled as much as we can. okay? Because when our patients get up, we don't want them to fall or to get tangled in those things and get hurt, okay? Be laying on them because it causes skin integrity issues. Okay? All right, so we talked about CUSIN already, and the CUSIN safety competency for a nurse is defined as minimizing risk of harm to patients and providers through both system effectiveness and individual performance. So it's not just us alone, that includes the organization where we work. And these objectives are the same ones that are in your SID. Okay, so a patient's environment includes physical and psychosocial factors that influence the life and survival of the patient. Does this sound familiar? We already talked about that this morning. Yes. Patients holistically, we have to care for a patient. So where they come from, their lifestyle, their culture, their experiences all affect our care and influence our ability to be able to keep them safe and educate them. Okay? But our environments can change. It's not always the hospital in which we treat patients. Which other environments might we treat patients and need to keep them safe?
At home.
At home?
Nursing home.
Maybe at the nursing home. So that would be a long-term care facility. At the clinic.
School.
At school, because we have school-based clinics. We have school nurses.
Out in the field, if you happen to, I don't know, someone needs a nurse.
Yeah, I try to stay out of those situations. No, I'm just kidding. But yes, no, community centers or community activities, because how we do health fairs, right? And screenings and stuff. So we have to keep our patients safe in all those situations. Safety includes both our patients' well-being and ours. So we have to keep ourselves safe. One of the things that I will tell you that you should always keep yourself between the door and the patient. Don't let the patient be between you and the door. Okay? We have to make sure that we're well in order to take care of someone else. So when we're sick, we have to take care of ourselves. So a safe healthcare environment, it reduces the risk of injury. That includes minimizing falls, patient inherent accidents. I told you I'm clumsy, so patients who wear glasses or who are old, they're going to have patient inherent risks. Does that explain that well? Okay. Little kids, every visit that they make to the doctor, we have safety issues for them depending on their age. They fall in different categories where they're at risk more for things to happen. So we talked about little kids falling in buckets. When they're little, it's real talk. When they're little, they're 2, 3, they're first starting to walk, 1. The safety, that is one of the safety issues, is them falling into things. So you shouldn't leave standing water around, teaching the parents that, okay? There's a certain age where bike riding becomes an issue. So bike riding without a helmet, we talk about that. As they get into teenagers, driving cars, we get into young adults, it might be sexual experience or experimenting with drugs or alcohol. As we continue to get older, it becomes falls or work-related injuries, okay? So every age category has safety concerns that are related to them because of developmental issues or where they are in their life, okay? So the procedure inherent accidents. So when we do procedures, we've been talking about surgery this morning. We'll use that one as our example. There's other procedures. Before we have a surgery, there is a protocol. It's called a timeout. Every surgery known to anybody, at least throughout the United States and even in other countries, should have a timeout before it's done. That is a procedural safety thing that's done to ensure that we're doing the surgery on the right person, on the right body part, with the right instruments, the right staff, all of the above, okay? So those would be procedure inherent accidents or safety things that could be prevented. And there's other ones that apply to others. That's just my example. Equipment related accidents. So I talked about the IV pole and STDs. Like, don't leave a patient, an elderly patient who can give up and who's not paying attention to the bed alarm in STDs. What's going to happen to them? Do you guys remember what I told you they are? So they're sequential compression devices. They hook on to the patient's lower extremity and they pump to keep circulation going. So they're attached to them. They're attached to the end of the bed. If I'm a confused patient that keeps getting up out of the bed, what's gonna happen? They're gonna trip over them. They're going out the bed because they're trying to get out the bed, and we just add it to that. So if I got all that going on with my patient, even if it's ordered, I'm gonna make the clinical judgment not to put them home right now because you're gonna be at increased safety concern, okay? All right, so the other thing that comes out of environmental safety things, especially at the hospital, do you all remember us talking about our patient safety goals? Yeah, no, maybe. Hospital patient safety goals from Joint Commission? Yes, you should have also seen them in clinical. But I have a lot of confused faces looking at me, and that's scary. So, our patient safety goals, the Joint Commission does annually. And those goals come from safety concerns that are seen across the nation. So this year's safety goals, oh wow, did you see the one about surgery? Did we just talk about that? So it wasn't a coincidence that I talked about that one. It's seen across the country. It's one of our patient safety goals. But what that means is that across the country, people are continuing to make errors with not doing the protocol. If we know that it's an issue, why would we not do it? So that goes back to every day we have to decide what type of medical professional, healthcare professional we want to be, okay? There are certain things that we maybe sometimes can not follow the letter of the law, and there's other things that we have to follow the letter of the law, okay? And so understanding when we have to follow the letter of the law and when we can't it takes time. So for now, just follow the letter of the law. That's the easiest way to say it. On top of which, if we always follow the letter of the law, then we know that most likely we're going to have good outcomes for our patients, okay? So every year they come up with these. I can tell you that identify patients correctly has been on there for several years. It's the first thing you learn in nursing school. I'm pretty sure it's the first thing you learn in medical school too. It's to identify your patient. Yet we seem to be unable to do that correctly. Okay? So it continues to be a national patient safety goal. All right, so we already talked about developmental issues, and vulnerable populations pretty much are always little people and old people. Everybody else in between, hey, you're all right. Okay? But our most vulnerable populations are usually at the beginning of the lifespan and the end. Right? And then the other thing that we look at with safety, remember we talked about Maslow's hierarchy of needs? So the first hierarchy is safety.
The second one, physiological safety, life and belonging, self-esteem, self-actualization.
If you're falling off a cliff, are you going to worry about eating or drinking?
So it's like safety to the patient.
Okay, so sure. I obviously need to drink and eat first. If I can't breathe, I'm not worried about my safety. But when it comes to illness, like I have diabetes, I need to be safe first and then I can worry about my care. Does that make sense? The difference and why I said it that way. Okay, so when you guys use this chart, do the one that explains it like this. Don't do the just this. Because you need to understand what those pieces mean. Because when it's saying physiological, it literally means your body breathing, not health issues. Why are you looking like that? Oh, so yeah, I get people make faces at me and then I'm like I do watch to see like if people are understanding or like, so don't mind me. That's part of what I'm supposed to be doing. Oh, you're fine. I just want to make sure people understand, that's all. Okay, so keeping it moving. We talked about vulnerable groups. We talked about Maslow's. In our environments, we always want to be aware of what can cause or pose a threat to patient safety. And then educating our patients. Part of what comes under environmental safety does include our immunizations. Anybody understand or know why? Why would it be included under environmental safety?
Herd immunity.
For the vaccination?
Yeah.
You're close. But it's not herd immunity. But why would immunity matter? If you're not vaccinated, you...
And you can spread it.
Okay, so when we don't have vaccination, we affect others in the environment.
Is that not herd immunity? Or am I thinking of it different?
So herd immunity has to do with immunity that we get from the, not in this sense, without looking at the definition.
Okay, gotcha. I think I'm just grouping it.
Yeah,
Gotcha.
that's okay. So that's why immunizations follow other environmental, because either it affects the people who are unable to get immunizations, or those who have, because even though you get a vaccine, the amount of immunity, like, so does everybody understand how immunity works? Like, we're exposed to something, our body creates antibodies for it. So the amount of antibodies my body creates versus what Tiffany's creates may be different. So that sometimes having immunity doesn't mean we can't get the disease. It may just mean that it won't affect us as much as if we didn't have the vaccine at all. Yeah. Yes. So like the flu is the prime example. People say, oh, the flu shot doesn't work. Well, they can only, the flu shot, I think there's a certain amount of strains that they will vaccinate against. However, the belief is that, or the understanding is supposed to be that if you get the flu shot, you are at least safe against getting an extreme version of the flu. Like, it keeps you from being as sick. Does that make sense? So when we're explaining to our patients, we gotta make sure they understand that, because they're, oh, that flu shot doesn't work. Okay, well, it may not be the strain that you got, but hopefully you're not gonna be as sick as you would have been if you did not get it at all. Okay? Alrighty. So, Then we have pollution of the air, the land, the water, noise pollution. All those things can affect our patient as well. All right. Making sure our patients understand what a pathogen is, and the most effective way to keep themselves from being affected by it, which is hand washing. So just as it is important for us to know that we need to keep our hands clean and washed, we need to explain that to our patients as well. What's the number one pollutant that affects our patients? Well, don't think so broad. Think like in their homes.
Water.
And it doesn't affect everybody.
Allergens?
Smoke. That's going to be the number one that we talk about with our patients is secondhand smoke or if they're actually smoking. Okay. It's the primary, actually, cigarette smoke's primary cause of air pollution. Okay. Making sure that they have proper disposal of waste products. So, running water, running pipes. So, like, some of you, depending on the populations that you serve, may have patients that don't live in homes with working water or working toilets. Okay. And improper, or maybe they don't work the best. And so that can lead to infections, okay? When you don't have proper waste disposal and all that kind of stuff. Okay? That's you get your hepatitis A. That's the one that's from the stool, right? Yeah. And hand. The spread of TB. Those things come from pollution, like within a environment. Okay. All right. Physical hazards in the environment. These ones often result in physical injury or death. Motor vehicle accidents, poisons under the counters, maybe we ate them somehow, falls. Hey, I'm that 40-year-old man who decided I was He-Man and could get on the roof and fix whatever, and I fall off the ladder. Or could be a female doing it too. Fires. The most common start of fires comes from smoking. And then disasters. Okay. Unintentional injuries are actually the 5th leading cause of death for Americans of all ages. So any of those could fall within here. Car seats fall within physical hazards with the motor vehicle accidents, kids not being put in car seats or in car seats properly. And then I already talked to you guys about that, the age of those starting to drive, that 16 to 19, because they're learning to drive, so they're at risk with motor vehicle accidents. The falls mostly applies to the 65 or older, and we already talked about all the things with that. We should encourage people to have a fire extinguisher. Anybody know what else is a cause of fires besides smoking? Huh? Heaters. You can talk up so everybody can hear you. I mean, your answer was right. I just can't. You. Both of y'all be mouthing answers. It's okay to talk up. And then in our area, natural disasters, floods, tornadoes are probably the biggest ones in our areas. But obviously, it can include tsunamis, hurricanes, earthquakes, wildfires. It's going to be dependent on where you live. And then the one that we don't often think of that has become an issue in recent years is bioterrorism. All right, so what do we learn? So in addition to being knowledgeable about the home and healthcare environments and the inherent safety risks, nurses need to know a patient's developmental level, their mobility, what their sensory is. If I'm a diabetic patient and I have neuropathy, which means I can't feel things in my fingers and sometimes in my feet, am I gonna feel that hot stove? Guys, my aunt has neuropathy. I've literally seen her go in the oven and pick up a pan and put it on the stove. And we're like, stop doing that, stop doing that. Because she actually cooks, she owns a restaurant, but she does it all the time. And we're like, you're gonna burn yourself. My mom is her sister, I told you my mom's, but she still does it all the time. But she has neuropathy, she can't feel it. So she's like, it doesn't matter, I can't feel it. Yes, it does, you can still burn your hands, even though you can't feel it, okay? So sensory, their cognitive status. Do I have confusion? Am I developmentally, do I have a cognitive issue where I can't understand? Did I have a brain injury and I no longer have a sense of what safety is, okay? Lifestyle choices can be a safety issue. If I'm promiscuous and I don't use proper protection, that puts me at risk, right? Whether I'm promiscuous with using drugs or I'm promiscuous with having sex. What if I am an adrenaline seeker? No? Yeah. Those people who I like to go and jump off the cliff. Or I want to climb the building with no harness. Yeah, so the one guy who was known for it, he died a couple weeks ago. That was his thing. He went around climbing stuff and he wasn't attached to any safety equipment. Yeah, last week he died because he wasn't attached to any safety equipment. Right? It's sad, and it was his thing, but he was addicted to adrenaline. We can have addictions that we don't think about, guys, that aren't the most common. So we talked about last week, our minds are gonna be opened as nurses because we have to see things in a different picture than what we've always seen or we've only seen in our life, okay? I don't have to jump off cliffs to be an adrenaline junkie, by the way. Maybe I love motorcycles and driving them fast or fast cars and drag racing. Okay? There's different types of things that give us adrenaline, okay? And knowledge of common safety precautions, okay? So, when we were talking about our nursing process and we talked about assessment, remember part of that assessment phase was knowledge that we bring to the table, that we've learned. So that's what we're talking about here when we're saying nursing knowledge base, okay? We also have to be aware of special risks to safety that are found in healthcare settings. So we already talked about all the millions of things that we hook people up to. And that's the biggest safety thing in the hospital that we face with our patients is just we hook them up to things and put them at risk of falls. We talked about developmental stages already. They're covered in I forgot to write the page number down, I'm sorry. You don't have to memorize them, but have a idea, general idea for each age group. You'll get into the specifics of children and all that later. We really just study adult and foundation. 376, okay, there you go. Thank you. Page 376. Okay, it kind of talks about the general risk factors of each developmental age. Okay. So after we look at that, then we look at individual risk factors. Did we talk about all of these already? Somebody give me an example of a lifestyle one. Huh? Adrenaline junkie, yeah. What about impaired mobility? Somebody who has not answered today. Andrew.
Age.
Age? Are you saying I got impaired mobility just because I'm old? You said yes?
I was going to say a different answer.
Okay, so what at old age would make me have impaired mobility?
Loss of muscular function.
Yeah, so maybe my gait's off because my bones have gotten deteriorated, or I just have less muscle mass because I don't work out. I don't use them as much. Okay? And what might that cause me to have to use? A walker or a cane. People use canes first usually. But yes, okay, I like that answer. Somebody else give me a sensory or communication impairment. We have not talked about this one as much. You are, and you're not in this class. Okay, Jennifer.
A hearing issue or a vision problem?
Okay, so tell me a hearing problem, guys. Huh? So we have a patient that's deaf, maybe by birth. Anybody know a disease that you can have that might make you deaf and have issues that's not?
I can't remember, but herpes can cause it whenever it gets to your ocular motor nerve. It's like.
Oh, you really are a science person. You be getting me with them. No, that's good. I don't know what you're talking about. I'm sure it's right.
It's like cephalo something. It's a different, I can't remember, but it's something like that. But it's like oral herpes, but it goes to your ocular nerve instead. And not syphilis. It's like an actual inflammation of the brain. I'm just going to stop talking.
Oh, no. That's not a bad thing. I don't know everything in the world against prior relief. But no, that's good. So she gave you one. I will give you another. Is Meniere's disease. Okay. Meniere's disease. It can cause issues with your eustachian tubes in that, and it can cause your balance to be off and cause you to have hearing issues.
I thought that was Meniere's disease.
What?
Meniere's disease?
That's what I just said.
Oh, I thought you said Meniere's disease.
No. Yes. Sorry about that. All right. So, lack of safety awareness. Any ideas when this one might apply? Steve.
By using the oven as a heater in the wintertime.
I would not have thought about that one.
I only said that because it happened and she burned her house down and died.
Oh, that's sad. But that is true. So, one that, I wouldn't have thought about that, but yeah, someone using a heater, using their stove as a heater could be a lack of safety awareness. Okay? Someone with dementia, someone with a brain injury. Okay. All right, so those are all individual. Risk in the healthcare agency, medical errors. People don't follow directions, so they don't follow orders. Doctors, anybody skipping over part of a protocol or part of a standard that we're supposed to be following. TJC is it's part of the Joint Commission. They have a Speak Up campaign which encourages patients to take a role in preventing healthcare errors by becoming active, talking, being involved and informed participants in their care. We already talked about our national patient safety goals, and then environmental risks. So the other one that we didn't talk about in the healthcare environment, like we talked about lines and stuff that patients are attached to, we didn't talk about chemical substances that are there, and that usually affects us more than it does patients in most cases. There's a lot of chemical agents in the healthcare environment, and there's a big book called the MSDS, or did they change the name of it, Leslie? Is it still the MSDS? Yep. And it has every chemical literature in the entire hospital in it. And if you want to go read it, it's online somewhere. But there are times where you need to read it. So maybe you get a chemical on you, or there's a chemical spill in your department. Then you go find that list, and you find, not the whole list, you find the chemical that you're looking, and it'll tell you how to take care of it. Okay? So it does become important, and it's important for us to know what it is. All right, we'll keep it moving. We already talked about all these. Does anybody have any questions about these? We have falls, patient inherent accidents. procedure related accidents, equipment related. One other one I'll tell you guys, because we didn't talk about it as an equipment one, is if we don't use equipment properly. So like we have equipment for moving patients. If we don't know how to use it correctly and we try to move a patient, we can cause a patient to fall or something like that, or be injured. That's another example of one. So let's take a quick quiz. While caring for a child, you identify that additional safety teaching is needed when a young and experienced mother states that A, teenagers need to practice safe sex, B, a 3-year-old can safely sit in the front seat of the car, C, children need to wear safety equipment when bike riding, or D, children need to learn to swim even if they do not have a pool.
B.
That was a gimme, but yes, that's right. Children ages 3 and younger should be in a child safety seat in the back seat of the car. So, box 27-5 in your book. What are some assessment questions that we want to ask to help us with patient safety?
Have you ever fallen?
Have you ever fallen? That seems to be a popular question today. Do you have difficulty with dressing or bathing? So all of those are known as activities of daily living, or ADLs. So can you do these things by yourself? Do you need assistance?
This is a random fact. Does anybody know what the true definition of walking is? Anybody? It is a sequence of controlled falls.
A sequence of controlled footfalls? Okay, interesting. I did not know that.
So we're all at risk of falling.
Yes, that's very true. Okay. I know there's more than 2 questions in that box.
Medication history.
What medications are you taking? Yes, I'll take it.
Do you have any symptoms before you fall?
Do you have what?
Any symptoms before you fall?
Okay, so if you are a patient that's been falling, is there something that happens before that? So most likely that's going to be a patient that's having seizures or something of that nature, or they're having syncopal episodes. People shouldn't just be walking around randomly falling.
Oh, do you need us using bathroom, get out of bed, walking around?
Yep. All right, so we already talked about our risk for falls, risk for injury, some other ones, risk for poisoning. Do these all make sense? Risk for trauma? Okay, we would have a definition, and then we're going to plan for them. We're going to do patient teaching. We're going to put the poisons up higher. We're going to have a fall ban risk, all of that, okay? And all of these other ones, which you will see, this is just a tree, a decision tree that nurses can use to help them make a decision about interventions. It's in your book. I wanted you to see it just because it helps you think your way through that thinking, right? Okay. We already talked about most of this. We didn't talk about lighting, but obviously if it's dark, you're gonna fall. Okay? Assistive devices, following fall protocols, which is to putting the band on, putting the sign above the door, helping them to the bathroom. Restraints, chemical restraints need a doctor's order. That's a medication. Physical restraints also need a doctor's order. That's when we literally tie somebody to the bed, but we shouldn't be doing that as a last resort, okay? Side rails. If you put all 4 side rails up, it is considered a restraint. And it also can cause more falls than it does anything because people try to get over it and then they fall over the forehead. Okay? We already talked about fire extinguishers. And evaluation is always, did the intervention work? Do we need to do something else? Is it working? We're done. It becomes easy to talk through most of these beginning ones because they are all interrelated. All right, so I will post the notes for infection control because most of it you covered in skills. And so we'll briefly talk about it next week, but you already got lectured on it. So it's basically wash your hands and know what all the protocols are. Like, what are standard precautions? What are contact precautions? So on and so forth. Okay? And I will be posting a study guide within the next week. Guys, do not wait until we post the study guide to study. Okay? We're doing it to help guide your study so that as you move on to the next semesters, you're able to kind of pull out what's important and stuff. But don't wait till you get that to study, and don't only study from that. Now, if you study from it, will you know everything for the most part that you should know? Yes, if you can answer all those questions. But it is not gonna guarantee you the test, because there's things on there that you just need to know that maybe aren't gonna be on the test.